Good morning, all. Good morning, medical elders. Good morning, senior colleagues. Good morning, colleagues. You're welcome to the day 2 of our 13th annual general and scientific meeting, holding purely virtually, being hosted by Bayelsa State. Today, we'll have 2 plenaries and our election. The first plenary, the chairperson will be Professor Mukhtar Ibrahim. Co-chair will be Professor Charles Erege and Dr. Yinade Olateju. Rapporteur will be Dr. Datonia Briggs. The presentations for today will be updates on neonatal treatment guideline, levels of attainment of SDG, care of the newborn of COVID-19 positive mother, impact of COVID-19 on neonatal health. Lastly, we'll be taking an overview and current updates and concepts on severe neonatal jaundice. Also prepared today will be some product presentations. The JNCI group will be presenting innovative NICU solutions, meeting the needs of critical neonatal care, and another product presentation from Fabra Pharmacy. So you're all welcome. And today promises to be engaging, exciting, and interesting. So I will hand over to the LOC secretary to carry on with the proceedings of the day. Thank you.
Good morning, all.
Good morning.
Good morning. Okay. Yeah.
Good morning, all.
Good morning.
Good morning, Dr. Oyedeji. Dr. Laila.
Good morning.
Morning. Deputy Secretary.
Okay.
Morning.
Dr. Deji, we can hear you. Go ahead. Thank you.
Let's go on with the national anthem and the pledge.
Yeah, Sarah. Then I can move.
I pledge Nigeria, my country, to be faithful, loyal, and honest, to Nigeria with all my strength, to defend our unity and uphold our honor and glory. So help me God.
Thank you very much. We'll now call on the president of Nigerian Society of Neonatal Medicine, Professor Mustapha Bello, to give his opening remarks.
Hello. Hello. Good morning.
We can hear you.
Good morning, my senior colleagues and colleagues. You are once again welcome to the second day of our annual General Scientific Meeting, Bayelsa 2021. Today's session promises to be equally exciting, just like yesterday. Looking at the topics, an update on neonatal treatment guidelines, the lecture to be delivered by no other person than the Director, Child Health Division, herself, of the Federal Ministry of Health. You are welcome, Ma, and thank you for honoring our invitation. The other presenters too, our two former presidents and our current advisor, even talking to us on level of attainment of SDG 3 in Nigeria. Then the last two presenters on topical issues of today, COVID-19, Professors Eziaka and Professor Ebun Adeji-Igbe. You are all welcome, and thanks for honoring our invitation. Without wasting so much of your time, we move on with the presentation. Back to the LOC.
Thank you very much, Mr. President. We'll now hand over to the chairperson and the co-chairs for today's first plenary session, which is the third plenary in this event. So we'll hand over to Professor Mukhtar Ibrahim, Professor Charles Erege, and Professor Dr. Olateju. Over to you.
Good morning, Mr. President.
Good morning, sir. We can hear you, sir.
Distinguished members of the Executive Council, distinguished lecturers. It's my great honor and pleasure to welcome you to this plenary, along with my co-chairs, Professor Charles Erege, and hope that you would treat us as expected and to a marvelous session to be remembered. I welcome you all and invite you now to please go ahead with your presentation. Thank you. Well, the first of all, so the presentation. Thank you.
Thank you, Prof. The
Right.
first presentation, update of the neonatal treatment guidelines.
Okay. Good morning, ladies and gentlemen, senior colleagues of this distinguished association, and colleagues. I bring you greetings from the Federal Ministry of Health. I hope I'm audible.
Yes, you are.
You are. Thank you very much. So we've been asked to speak on the update of the neonatal treatment guidelines at this, this conference. Next slide, please. This is going to be the presentation outline as shown on the slide. I'm going to start by introducing, then I'm going to talk about the trends in childhood mortality, relevant World Health Assembly / country level policy pronouncements on neonatal health, intervention by the government of Nigeria to address neonatal mortality in Nigeria, i.e. in terms of coordination mechanism, guidelines, strategy plans, training curriculum, quality improvement materials, newborn health commodities, essential medicine list, the challenges we're facing, and then the way forward. Next slide, please. So looking at this pictogram, as we're all aware, and this pictogram has been shown severally, over the past 28 to 30 years, in terms of child mortality, we haven't done very well, as we can see. We've seen the under 5 mortality. It went from 193 and decreased to just 132 in 2018. The difference isn't so much. We still have a lot of work to do. Please go back to the previous slide. And then in terms of infant mortality, it's even worse, from 87 in 1990 to 67 in 2018. Then neonatal mortality seems to be on the increase, from 37 in 2013 to 38. We have a lot of work to do. I guess that is why we meet so often, to see which way we can chart forward so that we'll have a much better neonatal mortality and other indices. Next slide, please. And then when we come to the neonatal mortality, according to WHO, it's telling us that the major cause of neonatal mortality is from preterm birth complications. It takes up 31% of the cause of neonatal mortality, followed closely by intrapartum related complications. The lowest cause is from diarrhea. However, next slide, please. Next slide, please. However, when we look at our VASA report, it tells us that majority of the cause of neonatal mortality is from sepsis, both from the physician coded and the expert algorithm. We see that sepsis takes up 23%. If we were to add pneumonia and meningitis, which on their own too are forms of sepsis, it's close to 40%. So we have a lot of work to do in terms of reducing sepsis as a cause of neonatal mortality. Next slide, please. In terms of neonatal guidelines, starting from the relevant World Health Assembly pronunciations, in 2014, Resolution 67.10 of the World Health Assembly, which at the country level, we adopted to the National Strategic Health Development Plan 2, which is to run between 2018 and 2022. Strategic Plan 2 addresses the increased EPHS under this is the priority area 4 that addresses reproductive, maternal, newborn, child, adolescent, and elderly health plus nutrition. Under this, we have a Nigerian Every Newborn Action Plan, which is the overarching document we use to address all other issues concerning the neonate. Before that, the Nigeria Every Newborn Action Plan 2016 to 2021, which we now want to review, priority area 4.5.1 addresses strengthening policies to implement at scale, such as to develop or update policies, strategies, standards, guidelines, and tools relevant to A, the content of the intervention package for newborn care, and B, required commodities such as medication, supplies, equipment, essential to implement the intervention packages. The NANAP further articulates in priority area 4.5.2 the need to establish, strengthen special care baby units as secondary facilities and the more advanced neonatal intensive care units in select tertiary facilities. In addition, the package of health interventions, area 4.1 for the newborn intervention, clearly articulates the need for comprehensive advanced neonatal care in referral centers by stating that certain newborn interventions must be delivered at referral level, namely the use of antenatal corticosteroids, advanced neonatal resuscitation, antibiotics for premature rupture of membranes, surfactant used for respiratory distress syndrome, and continuous positive airway pressure for RDS, pulse oximetry, as well as screening for sickle cell disease. All these are to enrich the care of the newborn and to reduce neonatal mortality. And all this is packaged in the Nigerian Every Newborn Action 2016 to 2021, which is currently undergoing review. So what interventions have the government taken to address neonatal mortality in Nigeria? Looking at the screen, we'll see quite a number of documents, starting from the, please can you go to the previous slide? Starting from the document I was speaking about, the Nigerian Every Newborn Action Plan, and there's also the Kangaroo Mother Care Operational Guidelines. Then there's also the second National Strategic Health Development Plan, 2018 to 2022, which is a roadmap to our healthcare plans for the year, for the country for these years, 2018 to 2022. Next slide, please. Next slide, please. And then we have the National Integrated Pneumonia Control Strategy and Implementation Plan 2019, the National Guideline for Basic Newborn Care. All these documents are already printed and about to be launched. There are quite a number of them. So in terms of coordination, what is the government doing to address neonatal mortality in Nigeria? Late last year, the Honorable Minister, Dr. Hanire, inaugurated a coordination unit, RAMCA plus N platform, which cuts across the different areas in terms of these different sections in family health provision to the nation. And they were charged, the platform was charged with the duty of overseeing in the different areas, to also step it down to the states, to see that coordination in the areas of reproductive, maternal, newborn, elderly, adolescent, and health, plus nutrition is well looked into. And then also this year, the Honorable Minister as well re-inaugurated the National Child Health Technical Working Group. This was in March. And we added a new subcommittee, that is the children with special needs, so that we see that no child is left out, that all the children are well taken care of, even those that we feel are not able to cope with everyday living. So he inaugurated a new subcommittee called Children with Special Needs into the National Child Health Technical Working Group. And all the other subcommittees were also re-inaugurated, and I believe they have started working. Also, the maternal newborn, please, next slide. The maternal, newborn, and child health quality of care technical working group was re-inaugurated. We have the professional bodies as well. They help with coordination mechanisms in delivering newborn health care. We have also, that is NISONM, and we have the Pediatric Association of Nigeria as well. In terms of policies, can you go back to the previous slide? It's not here. In terms of policies, which policies has the government come up with to assist us in creating guidelines, strategic plans to assist in the care of the newborn in the country? We have the National Strategic Health Development Plan 2, we have the National Health Policy, and we have the Child Health Policy, which currently is undergoing review, and the task shifting and task sharing policy. Then in terms of the guidelines, what documents do we have available now? Next slide, please. So we have the National Strategy for Scale-Up of 4% chlorhexidine gel in Nigeria, March 2016. It's about to be reviewed. The Nigeria Every Newborn Action Plan 2016 to 2021, the review is ongoing. The National Guideline for Basic Newborn Care, a lot of work has been done on this. It's been printed. So we're just awaiting the launch by the Honorable Minister. Same thing goes for the National Guideline for Comprehensive Newborn Care, the Kangaroo Mother Care 2, Kangaroo Mother Care Operational Plan guideline is also ready for use. We're awaiting the launching of these 3 documents. And then currently in use, we have the National Integrated Reproductive Maternal Newborn Child Adolescent Health plus Nutrition Strategy. It's already being utilized. The National Strategy on Quality of Care for maternal and newborn health is being utilized. National Pneumonia Control Strategy and the implementation plan is being disseminated. It has been launched and we're actually disseminating it in different parts of the country. The RAMCA plus N COVID response plan is already being utilized. Then the accelerated reduction of maternal and newborn mortality in Nigeria is being utilized. Finally, the maternal newborn child health social behavioral change communication strategy 2019 is being utilized. So there are a lot of documents. I have even left out some. All these documents can be accessed on the Ministry of Health website. In terms of the training curricula, we also have some documents there. We have the second edition of the 2019 Essential Newborn Care course. Currently, it's being utilized. And then we have the Maternal and Newborn Health Quality of Care Training Manual 2018 is currently being utilized. The Program Management Course Training Materials is currently being utilized. Then we also have quality improvement materials. We have the integrated supportive supervision tools, the newborn essential solution technology quality improvement tools, that's the NEST 360 QI tools kits, the maternal perinatal death surveillance and report response. The bill is awaiting to be passed. It's ongoing. The ministry has already submitted it and we're just waiting for the National Assembly to pass it. This will greatly enhance reporting of deaths in the community and we'll have better health records so that we can have data to work on. Then in terms of our newborn health commodities, can you move to the next slide? In terms of the newborn health commodities in the essential medicine list, what do we have there? We have the 0.5% erythromycin eye ointment. All these are used at the community level in the PHCs and also in the secondary and tertiary centers. They have been approved and are available in the essential medicine list. The 4% chlorhexidine gel, the amoxicillin dispersible tablets, ampicillin capsule, and then we have injection benzyl penicillin and injection gentamicin. And then we now ask ourselves that what challenges are we facing in the health sector as relates to delivering care to the newborn? Will I say, unfortunately, most of our activities in the newborn are donor-driven, so that we're sort of, we're in a way being driven by the donors. They are the ones that are like dictating the pace, and that is something we should work hard as a country to see if we can change. Then we have low coverage of newborn health interventions and capacity building of frontline health workers. We intend to work on this so that in the next few years, we'll have a huge number of health workers, especially at the community level and primary healthcare level, to take care of our newborns before they are referred to the secondary centers. Then in terms of comprehensive newborn care, is still quite inadequate, especially at the first level referrals. But that is why so many workshops are being organized now to see that we have intensive training for our healthcare workers at the primary level. If we get it right at the primary level, then it becomes easier at the secondary and tertiary levels. So way forward for all of this, there is need for us to work together as a team. The health team should come together, work towards the goal of universal health coverage by 2030. And then we need to continuously engage at the subnational level on issues concerning the newborn health agenda. Institutionalization and adaptation of global best practices. We've got to move forward with the rest of the world and inculcate into our practice what is current in other parts of the world. Then sustainability through inculcating all these curricula that we have mentioned into trainings, both at the level of nurses and health technology, and even in medical schools. If most of the things we're discussing here in terms of these documents are taught to these health workers while they are still in school, it would go a long way to improve our healthcare delivery to the newborn. And then there's need for us to continue advocating to all stakeholders, all partners at the National Assembly. We, as much as possible, make our voices heard so that we'll be the ones speaking for these newborns that don't have a voice. At this point, I'd like to stop and say thank you for listening. Thank you very much. Over.
Thank you very much, Dr. Mosu, for an excellent presentation. Also for letting us know that most of this material is available right from the site of the Federal Ministry of Health. Now, are we going to take questions now, or?
Yes, we'll take the questions.
Okay. Anyone with a question, please either raise your hand or just proceed to open your mic and let us begin. Questions for Dr. Mosu?
Good morning, Chairman.
Morning.
Can I go ahead, sir?
Yes, please.
Okay, my name is Dr. Fajolu from Lagos. Look, I want to thank Dr. Nwosu for that excellent presentation and updating us on what is being done at the federal level concerning improving newborn health. My comment is, how does the ministry circulate these documents? Because you've shown us a lot of documents. I know we've gotten these documents, some of them from previous NISOM and PANCOF meetings. But apart from individuals getting this from conferences, is there a set method by the ministry of circulating these documents to all institutions so that people are aware? Because there will be some centers that won't go for conferences and they may not even have seen these documents that you are showing us. Is there a way you send these documents to all hospitals so people are aware of what the ministry is doing and what they should be doing concerning newborn health? Thank you.
Do I take all the questions?
Oh, you want to take all the questions? Okay. Any more questions?
Yes.
Yes.
Hello, sir.
Oh, hello, go ahead.
Okay.
Identify yourself and then ask the question.
My name is Dr. Audu Lamidi.
Okay, Dr. Audu.
Yes. Thank you very much, Dr. Nwosu, for that presentation. My question is on the challenges that came towards the end of the presentation, because with those challenges, it will be difficult, even with all the guidelines we have and all the activities that are probably done to implement guidelines. Those challenges are going to be a bit stumbling block for making sure that we succeed in those activities. Are there plans in place to take care of that? I mean, one of those challenges is really the one that has to do with donor-driven programs. Does the ministry have any plan in place to make sure that at some point in time, this particular challenge, which has been with us for a long time, is taken care of. Thank you.
Okay, I have a question. I've raised my hand, Professor Mokolo.
Good morning, please. May I go ahead?
Yes, please.
Yes, go ahead.
Thank you very much. Good morning. My name is Dr. Tongo from Ibadan, from UCH Ibadan. Thank you, Dr. Onwosu, for that excellent presentation. And I would like to commend the Federal Ministry of Health for making efforts to get all these resources. These resources are actually very rich, but in line with Dr. Fajolu's comment, these resources hardly get to the hands of those who need to use them. So I'm happy to hear that, I mean, we have them now on the website of the Federal Ministry of Health. So the thing, my suggestion would be that how we ensure that people know that these things are there and they use them. And I believe we can actually use many of these professional associations to disseminate these things, to at least let them have the links, let them disseminate to their members, so that those who need to use these documents would actually have access to them. Then with respect to the area of training, including many of these things in the curricula of our training institutions, medical schools, nursing schools, and the various schools that really need to teach their students. How about making the MDCN, getting them involved in ensuring that they push for the various schools to include the necessary aspects of all these documents in their curricula, so that it will be widespread. Students will know about these things even before they go out to practice. So because many people, what they practice with now is what they had learned 20, 30 years ago, and they've not updated. So we need to keep updating these things. So if the Medical Council can be involved, I believe it will go a long way in ensuring that schools keep including these things in their curricula as they come out. Thank you very much.
Hello, good morning.
Good morning.
Morning.
Good morning, sir.
Yeah.
My name is Dr. Lateji. I want to thank Dr. Onwosu for the beautiful presentation, ma'am. I just look at the way forward after the list of challenges, and the first thing was on teamwork, as well as the sustainability of sustainability plan. So I don't know how at the federal level, how we are collaborating with the states as well as the local government areas, because whatever we are seeing at the teaching hospital or the federal level, it's just minor compared to the burden of the challenges that is going on at the state level, where they do not even have the basic materials to attend to this baby. And that actually explains why most of the deaths are actually coming from that area. So I don't know, I want you to throw more light, ma, on that, how you correlate, how you collaborate with them, and how you ensure that whatever you're advocating for at federal level is also being carried out at the other levels. Thank you, ma'am.
Okay, thank you very much. Can I go ahead? Professor Mokolo here.
Yes, bro, continue.
Okay, thank you. Yeah, so I join others to congratulate you, ma, for your presentation. Two things. Number one is that what exactly is the strategy for cascading, for translating from these various documents into an action plan? Maybe having a critical mass, for instance, of trainers. And so there's a deliberate training of trainers, and this is done strategically so that you have people who have been taken through many of these new orientations, and then they can propagate that within the sphere of their influence. So what is that strategy? Because many times donor-driven activity simply goes to the area of intervention, build a few local capacity, and then we have challenges with sustainability. Secondly, what is the linkage between several of the existing NICs and the data collation in terms of either the DHIS, having a connection with the various NICs at the central level? so that there is some form of update and real-time data that is also being collated, and maybe not just verbal autopsies and things like that alone, so that we actually have true data coming from our health facilities about newborn care and outcome, particularly from tertiary, secondary levels, where you have centers connected to the national DHIS.
Good morning, sir. My name is Bosse Toma. Can I continue? Sorry, sir. I hope you had finished.
Yes.
My name is Bosse Toma from Juice in Jos. Thank you, Ma, for your presentation. I just want to remind us, or maybe bring to our attention, the fact that, as we bring out these policies, we need to look at our environment and see how we can adjust some of these policies to our peculiar environment. We need to remember that many of our mothers are still delivering at home. So even as we, train and all that, and even up to the primary healthcare level, let's not forget the community. I know some of our policies are into the communities now, but we still need to do more as we look at that short term, and then we plan for long term. If not, this neonatal morbidity and mortality has not really changed much. So we need to look at what we can do differently, look at our environment and see how we can address our own problems. As we get policies and things from WHO and UNICEF and all that, we need to look at how we can domesticate and apply it to our own community and our country. Thank you.
Can I respond to some of the questions now? Can you hear him?
Please go ahead, ma'am.
Okay, I'll try as much as possible to answer all the questions, but if I leave yours out, then please, it's not intentional. So the first question was, what are we doing to make sure that these documents are widely circulated to reach all users? As you know, it will be quite difficult for these documents to reach every person. However, we are trying as much as we can to make sure we do that. That's why the first place to access these documents is on the Federal Ministry of Health. Come to Abuja. You can also, we can also avail you of these documents in the Department of Family Health. We'll later post on the message column the website where you can access the document. And some partners are also they're also assisting us in disseminating these documents at the state and local government levels. Then, in terms of what are we doing to reduce the donor-driven aspects of most of our programs, the federal government of Nigeria is trying as much as it can to make more funds available for healthcare. And so that is why the basic, which constitutes 1% of the consolidated, is being made available at all levels to address most of the health issues, apart from the usual budget that is assigned to health. We also have the basic healthcare funds being made available to prop this up. And also, of course, we can also reach out to the private sector. It's part of what the government is doing, partnership with the private sector to assist in reducing the donor-driven aspect of our health interventions. Then Dr. Tongo mentioned about us reaching out to Medical and Dental Council of Nigeria to incorporate these documents into the training curriculum for medical students. Yes, it's a very laudable idea, and we're in the process of doing that. And somebody now also asked a question about what is the level of collaboration between the federal government and the states and local governments. As much as possible, we offer technical assistance at that level. We go out to the states, to the local governments, we go and train their health workers. We do and also disseminate these documents that we're talking about. After training, we go for follow-up and also retraining from time to time. We're very much working in partnership at the state and local government level. And then there's only so much that we can also do in terms of health. We should remember that health is on the concurrent list. Each state is supposed to do as much as it can to take care of the health needs of its citizens. But that notwithstanding, the federal government, and in particular the Federal Ministry of Health, still partners at state level to assist in terms of the technical aspects. And we also have the National Council of Health meetings. We have it every year, where at that level, the Honorable Minister of Health is the chairman, and then the commissioners of all the 36 states are there, including the FCT, where they rub minds and issue policies and on how to run the affairs of health at the state level in conjunction with the federal. There was also a comment on there was a comment on the VASA, on VASA. I don't think I actually got that particular question properly. However, I know that every 3 years, in conjunction with most of the consultants, we carry out this verbal autopsy reports. And there's a unit in the Federal Ministry of Health, yes, Health Planning, Research and Statistics, that we collaborate with. And all this data are eventually uploaded into the national data platform. I don't know if I've taken all the questions, but I've tried as much as possible to answer most of them. I hope it has helped in some way. Thank you. Thank you. Over and out. Can you hear me?
I can hear you.
Yes, so I've
Thank
attempted
you.
to address all the questions. Thank you.
Thank you.
Chairpersons, we're waiting for you. Thank you, sirs and ma'am.
Hello. I think time is not on our side. So we thank Dr. Nwosu for a splendid presentation and answering most of the questions. I think we'll have to step it down, or just give you 1 minute to wind up your comments, Dr. Nwosu, and then we'll move on to the next presentation. Thank you very much.
Sir, she has wound off. She's gone out.
Oh, okay.
We can go to the next presentation.
Move on to the next presentation, please. Hello? Okay.
Good morning, distinguished, the chairman, distinguished participants. We are going to talk this morning in the following minutes about the MDG3 and the neonatal related components. I'm going to share my screen. Sorry. I have a bit of difficulty trying to locate my presentation. Can I get help? Are you seeing my screen now?
Yes, we are, but it's not the presentation. Did you send it to the ICT?
Yeah, I did. I sent it to you.
Okay, ma, do we share it from here?
Please, let's share from the end, the ICT end, please.
Okay.
Okay. I am going to go through the presentations rapidly. Pity I cannot do my own thing. I have now located my own presentation. Can you see my screen now?
It's not stable, ma.
It's not what?
It's not stable. It's off again. Oh, except it's from my end.
Can you see it now?
No.
Okay, it's coming.
That means
no, it's up.
It's up, ma.
Yes, you can see it now.
Okay, thank you. I'm just going to spend the next couple of minutes talking about the level of attainment of SDG 3, the newborn related SDG. We know that SDG 3 is key and central to all the other SDGs, and we are going to focus mainly on SDG 3.2. We know that the SDG 3.2 2 addresses the child related MDG, the under 5s. We can see the position of Nigeria, which still is not achieved the desired 2.5, not nearing attainment of the desired 2.5% because of the neonatal component. We have all heard about the constraints this morning. Well, I'd like you to look at Cape Verde, a country. Is there a problem?
Prof, your slide is not moving.
I am moving my slide.
Okay, it's moving now.
I'm moving my slide.
Sorry about that.
Okay. Nigeria and Cape Verde have similar GDPs, interestingly, yet Cape Verde is nearing the desired target of 2.5%. And Cape Verde is a cluster of islands in West Africa. It's important to realize that the strategies needed to attainment of SDG 3.2.2 are different from the strategies required for attainment of MDG 3.2 in general, because the maternal and newborn health are closely interrelated, cannot be separated. What affects the mother affects the baby. So we need to reorientate and have a different set of actions to focus on the less than 28 days old. How are we going to do that? We need to adopt a life cycle approach as the most effective method. For example, antenatal care, now referred practice implemented. Is there a problem, Dr. Ilo? Is my slide?
Prof, I think what we are looking at here is the admin slide.
Oh, you want me to do it as slideshow? Is it better?
Hello, ma, please, can you use the slide being displayed on the screen? So it would help you to control it.
Let me use my own. Let me control my own, please. That is where the problem is. I am sharing screen. Or is my screen not being shared?
No, no, no.
It's not being shared.
Please, can we give her the permission to share so that she can share hers?
Please let me share mine. When I started, somebody said they were now seeing my screen. What do you want me to do now?
Okay, ma, can you click on screen share? Then you select the slide and share it.
In fact, I had left that stage now. Okay, let me go back. We were all happy that I had found my slide. Can you now see my screen? You can't see my screen.
We can see it now. Go ahead, put it on slideshow, man.
Okay. Because when I started, you said you could see, and all of a sudden, somebody. Okay, now I've gone to some reasonable distance now from my presentation. I was saying that we need to apply a different type of strategy to achieve mortality reductions for the less than 28 days old, different from the strategies we apply for the older child, under 5. And maternal and neonatal health are intricately related. If we look at the attainment for the maternal mortality reduction or the maternal health, the target 3.1, we find that we are far from reaching the the mortality ratio of 70 per 100,000 live births. This is what it is. Look at Nigeria standing high. We're still at the level of about 800%. So now, you can't see again.
We can see.
Go ahead, Ma, we can see.
We can see you.
Okay. And now let us look at other components of maternal health aspects that must be influenced to effect a reduction in neonatal mortality. We're looking at skilled birth attendants. Look at the place of Nigeria in Africa. We are still at the level of 40%, which is rather low. We will get to know that there is relationship between the skilled birth attendants, and delivery, and the neonatal mortality. If we look again at Cape Verde, I keep comparing Cape Verde to Nigeria because we are in the same range of GDP. We find that Cape Verde, that has a 90% SAB, relative to Nigeria, who has an SAB of about 40%, has a very low neonatal mortality. Look at the comparison of skilled attendants at birth and neonatal mortality ranges. We can see again where Cape Verde stands with her 90%. She is looking at a very much lower neonatal mortality rate. Now, the target 3.2 that neonatal mortality comes under is 25 per 1,000 live births, where 12 per 1,000 is the portion ascribed to neonatal mortality. How far are we from that? We can see that most of Africa still needs to meet this target. Now, to meet this target, it is very crucial that there is neonatal mortality reduction, where we will be looking at a reduction of having a survival of 97.5% of all newborns by 2030. Now, our survival rate is at about 38%, we were told. Look at where Nigeria has reached, and look at where Cape Verde has reached. So we are far. The neonatal mortality definition, we all know what it's about, so we're not going to take our time. We are clustering around the Afghanistan, Mali, that's where Nigeria is, and Mozambique. We are still very far to attainment of this SDG. We can see again the chart showing where we are. We are very, very far. Nigeria tops high in the continent, and we are now at a level of 38%. That's what this graph is showing us, whereas Cape Verde is less than 10. So the Cape Verde is likely to meet this target, whereas Cape Verde was also remarkably one of the countries that achieved the MDGs. Here again, this is the toll of neonatal deaths, and this is where Nigeria stands. There has been substantial progress in attainment of SDG 3.2, but there has not been much change for in the path of progress for SDG 3.2.2. various factors are in play. We have the socio-economic and demographic. We have the maternal and the sociocultural issues. We have health system issues and inequities. The barriers that influence health facility utilization by mothers include disparity in population distribution of wealth and services between urban and rural. And we find that the poor in urban communities and the rural communities are equally affected by this disparity in the utilization of wealth, distribution of wealth and services. Such factors limit access to health care as geographic terrain. For substantial improvements, these barriers must be tackled through concrete programming to improve access to quality health care. We must be able to address inequitable distribution of healthcare facilities and human resources for health, because these limit provision of quality care. Community conditions have also an influence, such as physical and social service provision. This is exemplified by the fact that children born without skilled attendants at delivery are more likely to suffer severe morbidities at birth or experience greater mortality within the first few days of delivery. We can take from the last presentation that most of our population are still delivering with traditional birth attendants and are still delivering in the communities. The major barriers are effective healthcare interventions are underutilized, and they are related to income disparities. So these are demand side issues. There also, we talked about the geographic terrain limiting. In rural areas, we have low density of modern healthcare facilities and poor transportation systems and road infrastructures. This leads to delays in seeking health care. And in that context, of demand, the adverse socio-economic cultural practices also influence. There are high illiteracy rates that we still have to combat. We have socio-economic barriers that are resource-related barriers. These are supply and demand side. The supply side barriers will include health system finance cutbacks. There's limited funding for health in Nigeria. This results in acute shortage of human resources for health. We have a relatively low ratio relative to the recommended ratio by WHO. We have inadequate supply of drugs, and there is coverage and quality of healthcare interventions, even when the staff is there. Understaffing of healthcare personnel is a very crucial issue. Inequitable distribution of healthcare facilities and human resources for health limits provision of quality care. And this brings about inequities in mortality reduction. There are higher mortality rates in poorer communities with poorer access to care. This is more in the rural communities where healthcare facilities and high quality of care are limited. So on the supply side barriers, we need to have prioritization of specific aspects of maternal healthcare service delivery, and we need to strengthen the capacity. I was happy that the Director of Family Health, Head of Child Health, has referred to strengthening capacities. And we need to enable this strengthened capacity to deliver context-sensitive, specific maternal health care intervention at all levels. There are fewer health facilities in rural communities, so their numbers need to be increased. Such factors may perpetuate underutilization, even though quality care is closely related to child survival. These barriers prevent mothers and newborns from accessing the health facility. Studies have long established that distance from healthcare facility also influence utilization. We find that there is a wide gap in neonatal mortality reduction in poor, hard to reach areas, and where the transportation system and road infrastructure is limited. In fact, in the study of Frankenberg, they noted that the proximity to a healthcare facility significantly decreases mortality, while a slight increase in the distance to a healthcare facility leads to a corresponding increase in mortality. Notable barriers in demand and supply include maternal education, resource-related barriers that impair utilization. This is exemplified by difficulty in getting money needed for medical treatment because currently the clients pay out of pocket. There is shortage of health workers and inadequate supply of drugs, even when they access the health system. These are some of the resource-related barriers that impair timely access to quality care. What are the solutions? This should include strategies that will ensure equitable distribution of health care across the regions of the country. An increase in the density of modern health facility. In fact, we should just adhere to the recommendation of the PHC. This might resolve the problem. We should identify and implement strategies that should cover the gaps in the shortage of health personnel, inadequate supply of drugs, shortfalls of health funds due to health budget cutbacks resulting from the economic crisis. This has even been worsened by the situation created by COVID-19 related economic crisis. We should strengthen and prioritize women's health by adopting a holistic multidisciplinary approach. This approach should link together biomedical and sociocultural and economic factors. Such policies will address women's health, education, and economic benefits to the advantage of labor productivity because the women produce a substantial amount of the food we even eat. And this will enhance national economy and improve child life and child health. We should promote implementation of integrated programs as has been recommended and advocated by KEBA and the GRAF. They have talked of continuity of maternal, newborn, and child health, which usually refers to continuity of individual care. Continuity of care is necessary throughout the life cycle. And when we're talking of continuity of care, it affects the individual as well as the community. It will involve public level or public health framework based on integration of services. And according to their recommendations, it could be delivered through 8 packages to promote health for mothers, babies, and children. And these packages, 8 packages, would deliver what could have been delivered in a vertical manner, resulting in 190 separate interventions. So it is profitable to adopt that. So the continuum of care packages encompass 3 packages delivered through the clinical care, 4 through the outpatient and outreach services, and 1 through integrated family and community care throughout the life cycle. Mothers and babies, given that mothers and babies are at high risk in the first days, you can observe that there is lack of a defined postnatal care package. This is an important gap, which also contributes to discontinuity between maternal and child health programs. Similarly, the family and community package tends not to be regarded as part of the health system because they are in the community. Few countries have made systematic efforts to scale it up or integrate it with other levels of care. So building of this continuum of care for maternal newborn requires effectiveness trials in various settings, policy support for integration. It requires integration at all levels. So policy support must be there. It requires investment to strengthen health systems and results-based operational management, especially at district level. So most studies that highlight barriers are best addressed by considering these barriers in a holistic manner. Prioritizing one barrier over another may not achieve positive results. So they should be approached at community level. Additional supply would be required on the demand and supply side. They usually must work in tandem, because if we begin to approach them vertically, it may not work. So looking at the barriers again, health insurance schemes currently exist in Nigeria, but they are limited. Yesterday, we heard that there's going to be a special component for neonatal care in the National Health Insurance Scheme, but there will still be the limitations. Now, let us look at what removal of user fee had done for some countries. Where they were removed in some countries, and that helped to increase utilization. But the countries had to go back rapidly to reinsert user fee because there were some limitations. Because such concerns about drug availability and concerns about services that will affect equity and the poor were not taken into cognizance. So they had to reintroduce user fees. Now, results-based financing has emerged as a potentially significant strategy to finance health and other social protection services in the health sector. This is mainly used for expanding the quantity and quality of targeted subsidized health services. It's often referred to as output-based aid, pay for performance, cash on delivery, and performance-based financing. This has shown some promising results because for the little token the poor pay, they get their coupons that entitles them to health care, and the provider also gets some incentives, so they encourage user. But it is in the context of private-public partnership that it may work, because a lot of our states are declaring free maternal newborn care services. And if they say it's free, then it's going to be, they are going to be hard put in such a public sector to operate the output-based aid programs. So now we are looking at the way forward. What will the way forward be? The way forward would be for NISONM to explore some of these approaches and swing into action and support the Federal Ministry of Health more. A holistic, the NISONM should be able to develop the format of the life cycle approach that would holistically integrate various components that would increase demand and supply factors and address various aspects of care for women and children with relevant partners. The life cycle approach, a bundle that can address 8 packages, needs to be studied and implemented by NISONM as a pilot to see how it can improve the situation. We've got a limited time to 2030. We should identify relevant partners to study and implement the voucher proposed approach, the voucher method, which addresses both supply and demand side barriers to improve utilization of services and reduce mortalities. Thank you for your kind attention and for listening. Here are my references. Did I meet the target time? Because I was given 15 minutes.
Okay. It's okay, but we're enjoying the presentation.
Hello, sir.
Thank you.
I don't think Prof is with us again.
Yeah, I'm done.
Olateju, carry on now, please.
Okay. We want to thank our professor for the beautiful web package presentation. Thank you very much, ma. We always appreciate you. Whenever you are presenting or talking to us, we don't want you to stop. Continue to talk. May God preserve your life for us, ma. Thank you.
Thank you. Thank you.
So now the time is not on our side, so we may not be able to take direct questions from our audience. So we advise that you send your questions or contribution to the chat box, and that we properly address later. So we now go to the next presentation by one of our friends again, Professor Chinyere Ezeaka. So ma, it's over to you. I think we'll have your presentation. Then at the end of the presentation, we look at the chat box to address the issue raised. Thank you.
Thank you very much. I'm still, it's saying hosts. It's not allowing me to share screen. The chair, co-chairs, distinguished colleagues and participants, very good morning to you. Can I share screen, please? I'm not being allowed.
Yes, you can. Yes, you can.
Go ahead, man.
He's saying the host disabled participants screen sharing, please.
Oh.
Can you try it again?
I don't have the sharing right.
You'll be allowed now.
Thank you very much. A very good morning to you all. I joined to congratulate NISONM on this first virtual meeting. And this morning, it's still not allowing. So
but you've been made a co-host. Could you try again?
Okay, thank you very much. Oh, great. Can you see the slides now? Not
yes,
yet.
we can. We can.
You can see my slides?
Yes.
Yes, yes, yes.
Oh, okay, sorry. Okay, so this morning I'll be speaking on care of the newborns of mothers who are positive for COVID. There's some, I need to put it on slideshow, please, sorry. Can you all see the slides, please?
Yes.
Yes,
Go
we
ahead.
can.
Yes.
Okay, but there are some videos blocking my view. Okay, it's out. Thank you so much. So thank you. I'll be speaking on care of the newborns of COVID-19 positive mothers. And I work at the Lagos University Teaching Hospital, Neonatology, Perinatology Unit, and the immediate past president of NISONM. I'll say that I don't have any conflict of interest for this presentation. And the outline of my presentations are as shown on the screen. The introduction, I'll talk about clinical importance COVID-19 in neonates, and then mention areas of care, starting from the delivery room, rooming in, breast milk, kangaroo mother care, discharge and follow-up on these babies, communication and counseling, and then zone into the Lagos University Teaching Hospital COVID-19 experience, where we delivered 20 mothers who were COVID positive. Wow. So the COVID-19 coronavirus of 2019 has taken center stage since 2019 and has changed all our worlds. When it was first described in December 2019 in China, Wuhan. And since then, up till now, the world has not been the same. The first case confirmed in Nigeria on the 27th of February 2020, and then a lot of activities and attention and agitation when the first mortality occurred in Nigeria on 23rd March 2020. But the major concerns were about the pregnant mothers and the newborns due to their relatively reduced immunoplegic state. So speaking about the clinical importance of COVID on mothers and their newborn, studies have shown that there is not a lot of vertical transmission of COVID-19 from the mother to the baby through the placenta. However, horizontal transmission has occurred during intrapartum period and the postpartum periods. And these are preventable. So if it is we're able to take up the precautions, we'll be able to reduce a lot of the intrapartum and the postpartum periods when these babies are infected after delivery. Current studies have also shown that highest rates of infection to babies occur when the mother got the COVID-19 near the time of delivery. Most infected neonates are asymptomatic, which is a very good news. And the ones that are even symptomatic have mild to moderate diseases, which can start quite early or maybe a little later within the 14 days of incubation. The multisystemic inflammatory response in children is extremely rare in neonates and has actually not been totally reported. But what don't we know yet? COVID is an evolving infection. The effect of COVID on the fetus, if the mother got the infection in the first trimester, is still not well known. So these are still areas for research. So what will be our objective if it is that we're talking about care of the newborn? We have to identify, resuscitate, and care for these exposed newborns early and provide optimized care for those babies who are infected. We have to ensure and interrupt human-to-human transmission, including reducing secondary infections among close contacts and healthcare workers as well. And then we must establish and maintain maternal-infant bonding as much as possible. We should not separate mothers and babies because these are duly unnecessary. So the delivery room practice, mother, as she's entering the delivery room, she must observe the hand hygiene and have layered surgical mask, appropriate mask for her prior to entering the delivery area. Then when this baby is born, the resuscitation procedures will be as same. We must ensure thermal protection, blended oxygen, early CPAP, but as much as possible, prevent a lot of the aerosolized procedures. Delayed cord clamping, immediate skin-to-skin care, early initiation breastfeeding must be as with routine practice. The precautions, the resuscitation corner has to be about 2 meters away from the delivery area, and the personnel must be fully kitted. Full set PPE, N95 mask, face shield, gown, gloves, and then you should use plexiglass head box if you need to do suctioning, intubation, and bubble CPAP, etc. Then we have to routinely clean and disinfect surfaces. This is an infographics trying to depict how the delivery area should be set up. This is the delivery room, full kit PPE. And then there must be like a curtain dividing the delivery area from the resuscitation area. And the health worker must be fully kitted. And then after delivery, what are the next steps? We have to consider care options based on criteria. We have to monitor the baby and the mother based on periodic assessments during the course of the admission. We should aim not to separate mothers and newborn. There are categories. In most times, the baby is stable, and the mother is either suspected COVID, and she's also stable. This mother and baby should be in a COVID postnatal ward, and this mother and baby pair should have direct breastfeeding. If the second category, if baby is COVID suspect or positive, but baby is stable, but the mother is ill, you nurse the baby in a well baby COVID ward. Then if the neonate is COVID positive, is preterm, once you have a preterm delivery, really think about the possibility of COVID, because up to 47% in studies of mothers who are COVID positive have been said to deliver preterm babies. Or if it is the neonate is sick, then the neonate has to be nursed in a separate designated isolation facility or NICU. But what can obtain here is having to pull patients together. This is how other countries and regions have done it. And for us in Nigeria, I know some centers were designated COVID centers where you pull these COVID mothers so we can have these designated areas. And the newborn care unit should have special areas for donning the gown and negative pressure, and areas for doffing and exits. So these are key to have the room well segregated and outlined. So if it is we have a suspected COVID neonate and the suspected COVID mother with a stable neonate, we talked about rooming in with precautions. These precautions basically hand washing before and after feeding the baby. The mother must wear a mask and then maintain cough etiquette. She must use the mask and won't cough on the baby, and then ensure she has a mask anytime she's holding the baby. Direct breastfeeding is what is advocated. Then to separate, if the mother is not caring for that baby at that point, there has to be some distance, about 2 meters separation, while not providing direct care. Then if it is the mother is confirmed COVID, but the baby is stable and the mother is stable, still the same arrangement will obtain, is also to room in and have direct breastfeeding. However, if the mother is sick, COVID, symptomatic, still with a stable neonate, then you have to stabilize the mother first, whereby the baby can be nursed in a separate room, if it's possible, adjoining close to the mother's room, with a dedicated care worker looking after the two of them. In this instance, this mother cannot be able to feed this baby directly because she's ill. She should be encouraged to express breast milk, and baby is fed EBM. Then the other scenario where this baby is ill, symptomatic, they have to be nursed in a separate designated isolation facility with a lot of attention and precautions being taken, both for the health worker and the baby, not so that this baby will have all the intensive care needed. All the usage of medications, chloroquine, hydrochloroquine, immunoglobulins, systemic steroids, have not been recommended in the newborn period. We have to do all the essential testing. We have to have the full PPEs, possibly nurse this baby in a closed incubator and have negative pressure. Then to have express breast milk for this baby. Some background noise, please. Then this is a schematic flow chart.
Participants, please, could you mute yourself?
Can we Thank you, thank you.
Participants, please check your microphones.
Please. Thank you so much. So this is a flow chart actually stating all that we've talked about, starting from when this mother comes to the delivery room and either the baby is well or the baby is ill. Sorry, this is crowded, but it will be shared with the slides and you can appreciate it better. Then coming to the area about breast milk, please can the host mute everyone? Thank you. Can the host has the ability, coordinator, please mute everyone that is not speaking. Thank you.
And then mute those.
Admin, please. Chair, co-chair. Thank you. Thank you so much. So we now talk about breast milk. My time is going, ladies and gentlemen. My time is going. Please, admin.
Admin, can you people help us, please?
I hope it's not from your side. I hope it's not from your own side.
No, I'm here alone. No.
Background noise.
Please, it's not from my side.
Should be muted. There are people, check them and mute them.
Yes, you see the people that are speaking, please.
Olanike Olutekumbi, please.
I think it's Olutekumbi. Please, can you people mute Dr. Olutekumbi?
I think they cannot.
I don't need that. Can't the admin do something?
Then the NCC should mute it now.
Are they still talking?
Admin can mute everybody, please.
Thank you very much. Thank you. I'm so sorry for the interruption. So you now come to breast milk, which we know is a lifesaver. Breast milk is best, is supreme, is superior. That is the mantra. So on no account should this baby be denied of breast milk. There were initial concerns about breastfeeding, kangaroo mother care earlier with COVID in 2020, but lots of research work, lots of systematic reviews by WHO, where they reviewed more than 15,000 reports on newborn and infants, and the current considerations have come up with recommendations that early initiation of breastfeeding and kangaroo mother care are two key interventions for optimal newborn survival. Earlier concerns about this transmission after birth through breastfeeding. The results have shown that no study has shown, no research work has shown the full virus being transmitted in breast milk. So the baby cannot be infected. However, a few reports noted nucleic acid particles in breast milk, and this cannot infect the baby. So latest research by WHO, CDC, and Nigerian NCDC guidelines all stated that COVID recommendations, the baby should be breastfed, that the potential risk of COVID, and then considering the risk of morbidity and mortality associated with not breastfeeding, the inappropriate use of infant formula milk, as well as the protective effect of skin-to-skin contact. The baby losing this is much more overwhelming, with infection in diarrhea, pneumonia being 14 times higher in these babies. So the mother should be counseled about the benefits of breastfeeding, substantially outweigh the potential risk of transmission with COVID. So we as health workers must support, we must protect, and we must promote breastfeeding at all times. We must support direct breastfeeding or express breast milk, provide KMC with precautions, the same precautions the mother and baby will have KMC, but the mother will be wearing masks during the KMC, and then she should wash her hands. And because initially it was a big concern in our unit, I know they said no KMC, no mother, no father. Everybody was really, there was palpable fear, and even about all the other babies. So the key precautions must be in place with respiratory hygiene all through, hand hygiene before and after feeding the baby. These recommendations were also captured in a collaborative network COVID newborn care collaborative group that was a large group of US, UK, Next 360, IKMC, led by WHO, where in March this year, we published Small and Sick Newborn Care During COVID-19 Pandemic, where there was a global survey and thematic analysis of healthcare provider voices and experiences, and Nigeria participated in this publication. Going further, we also had another publication on preterm care during COVID-19 pandemic, where kangaroo mother care and skin to skin were well recommended. So this question will come, COVID testing in well newborns, while I'm trying to round up. Testing well newborns will facilitate plans for care after hospital discharge because these babies are relative, they're all stable. It will also help to determine the need for ongoing precaution and use of PPEs for care of hospitalized infants. We need to know, is this baby infected or not infected? That will guide the care. And then we need to know about the baby's status to continue to contribute to understanding of viral transmission and newborn illness. Flagging on this last point, earlier in the first cases of COVID that we managed in Lutz, we wanted to know, was there transmission, vertical transmission? So samples were taken within birth 24 hours. We took cord blood, amniotic fluid, swab from surface skin, nasopharynx, breast milk, placenta tissue. And it's been noted that tests taken before 24 hours, actually now researchers are saying tests done before 3 days do not have a high yield. Then if baby was negative, the test was repeated within 48 to 72 hours before discharge. And then when they go home, we did the test again 5 to 7 days and 14 to 21 days to be sure that this baby is totally negative. However, if the baby is positive, baby is retested, so you have 2 negative tests. So looking at the current recommendation about testing, it's not too different from what it was, but it's now much more relaxed. First is that this baby should have a bath so that you even remove every potential virus particle on the baby's skin surface. And then baby should be tested once during discharge. It's not as elaborate as it was before. But again, when there are facilities and there are facilities available, baby can be tested within the first 24 hours and again, approximately 48 hours. Looking at the India protocols, they actually test this baby at 3 days before discharge and then do another test within 5 to 7 days, but before 14 days, to be sure that this baby remained negative and is not infected at home. Then the babies who are positive on the first testing are followed up till they have 2 consecutive negative tests. These are actually a lot of compilation from April 2021. Then looking at discharge again, babies know no main protocol that is different from what we normally do. We have to discharge them once they're medically stable, maintain the immunization schedules, have extra precautions at home so that this baby is not infected. And then we must tell these mothers to use the correct mask, not just putting it on their chin. It must be emphasized. Good hand hygiene, maintain standard postnatal care is very important. The issue about communication and counseling, a slide is dedicated to that because it's key. They need to understand what we're saying, the parents, inform and explain to the families about the restrictions and the treatments and the regular updates, advise them about the feeding, and then they should look out for danger signs on that baby. If there's fever, if there's respiratory distress, we can also use videos and telephones and teleconferences. We heard about telemedicine yesterday. These are areas where they are key to even monitor these babies up to 14 days to be sure that all is well. Then to talk about Lutz, to mention about Lutz delivery, the case series, between April 2020 and March 2021, Lutz Isolation Center managed 20 COVID-19 pregnant mothers. We had a multidisciplinary team of obstetricians, anesthetists, nurse, neonatologists leading the newborn team. And actually to say that even before we had our first case of COVID-19 mother presenting, we already had put together guidelines, which was published in conjunction with the obstetric team. So this is the first case, the first team after the cesarean section, where we had a dedicated K block for COVID delivery. the labor ward, the labor ward theater, and we had some rooms for the mothers. And this actually was quite proactive of the management and the dedication of the team. The newborns did not, many of them, they were asymptomatic. We had the mothers, sorry, we had only 5 mothers that were actually symptomatic. All the other mothers were asymptomatic, but they were COVID positive. Out of these symptomatic mothers with severe illness, we unfortunately lost one of the mothers because she had to be taken to the infectious disease IDU center, etc. The pre-existing comorbidities were chronic hypertension, and then 4 of the mothers actually has asthma, and this was significant. Looking at the babies, we can now see the preterm component. We had 6 of them being preterm and 1 stillbirth. No asphyxia, no jaundice, but it is key for us to note that all the babies were all COVID negative at the testing. This is the 4th cesarean section that was done in the center, where we had a set of twins that were also preterm. To note that these successes were also, the team worked well, proactive and documented in journals that can be referred to later. So it wasn't without challenges. We had, for us to have a full COVID-19 care for these babies, there has to be facility preparedness, working with the Federal Ministry of Health, working with the state, working with the professional associations, the nurses, the neonatologists, the pediatricians, all of us. Facility preparedness. We have to establish local protocols and guidelines to say that the COVID-19 is part of what has been captured in our current comprehensive newborn care guideline that will soon be due for dissemination. Assembling a multidisciplinary team, and then training and retraining of healthcare personnel is key. Then we have to have provision of adequate supplies and equipment, oxygen concentrators, pulse oximeters, radiant warmers, bubble CPAP, phototherapy, because all these were all dedicated. We had to actually collect one of the radiant warmers we had in the postnatal ward to quickly take when the first case came. We had protocols, but when the mother came, there was still a lot of chaos. We had to assemble there on a Sunday to do drills, so that hoping that the mother will not deliver the baby before the drill is finished. Then communication is key between the isolation ward, the obstetricians, the neonatologists, etc. And to say that these equipment are what the respiratory supports that the Next 360 program is working with the Federal Ministry of Health, that we must be sure we have at the secondary and tertiary facilities. So, very distinguished audience, my key messages are: newborns can acquire COVID-19 infection during birth and at home postnatally. There's not been proven much of vertical transmission across the placenta. So we can see that most of these infections can be prevented if it is we maintain the precautions. Affected neonates are mostly asymptomatic, which is very good news, with mild illness, and the prognosis is good. So we don't need to have all the antiviral drugs being put for these babies, like we had some reports earlier. Rooming in, breastfeeding, kangaroo mother care, immunization, and routine care should continue as per unit practices. We have to communicate with family, and this should be strengthened. Then there has to be a multidisciplinary team, protocols, trained staff, dedicated infrastructure should be major prerequisites as a country. And then the keys to protection: minimal handling, universal masking, hand hygiene, physical distancing, respiratory etiquette must be observed. These are my references. And to say that amid all the fear, everybody running away from the COVID ward, from the COVID center in Lutz, the team, dedicated, compassionate, and passionate, still had time to take action pictures with the first set of twins that were delivered. And this should be how passionate and committed we should be for us to care for COVID-infected mothers and their babies. Thank you very much for listening. Thank you. Over. Thank you very much. Hello, admin. Hello?
Hello, we can hear you. Let's get back to
Thank you.
the chair. Thank you very much.
Thank you very
Thank
much.
you.
Thank you very much for
Thank you very much, Prof, for the beautiful presentation. Thank you. We appreciate
I think
it very well.
we should go to the next paper by Prof. Ebon because of short, I don't know, out of time. So let's go to impact of COVID-19 on the mental health, after which we'll take questions on the chat and then go for a break. So Prof. Ebon, please go ahead.
Thank you very much. Oh, admin, please, can you give me hosting rights so I can share my screen? Admin, please. Admin, please, can you give me hosting rights?
Okay,
Go ahead. Go ahead and share, ma.
Thank you. Hello, please, can you see my slide now?
Yes,
hello.
we can.
Okay,
We
thank
can
you very
see
much.
it now.
Yes,
Okay,
we can see your screen.
Okay,
We
ma'am.
can see it, ma'am. Thank you.
Okay. So good morning, everybody. I want to thank the organizers once again and the leadership of NISONM for a wonderful organization of this conference, though virtual, but very impactful. Thank you so much for also inviting me to speak. The previous two speakers have actually dealt a lot on the part of newborn and also on COVID infections in neonates. I just want to remind us that the neonatal period is the most vulnerable time for a child's survival. We know that. We know that the average global rate, it's of death. It's about 17 deaths per 1,000 live births. That was of 2019 in babies who are less than 1 month old, as compared to 11 deaths per 1,000 after the age of 1 month but before first, and 10 per 1,000 after the age of 1 year up to 5 years. And so it's obvious that the newborn period is a very important period. And we know that about 2.4 million neonates die in the year 2019, and we are also aware that about 7,000 newborn die daily. And we say in Nigeria, over 700 newborn die daily. And we are compared that to a plane load of passengers, of 700 passengers crashing every day. I mean, that can happen. People will blink an eye. But this is happening in the newborn world, and nobody is perturbed. I want to actually thank the leadership of the Federal Ministry of Health, past and present, of what they have done in neonatal health, and the leadership of NISONM, because I know that in the last few years, the newborn health has moved, very, very, and made much progress, even in Nigeria. And this is a global display of neonatal deaths by country in the year 2019. You can see the African countries with a lot of dark red. The thicker the red, the higher the incidence, of neonatal deaths. And Nigeria, of course, you can see Nigeria there. Unfortunately, talking about the top countries with the high mortality rate in the world in the year 2019, after India, Nigeria is second. And that is not too good for us. So the state of the newborn in Nigeria is not very encouraging, even though, like I said earlier on, much progress has been done. There's still much to be done. 39 per 1,000 live births is the current neonatal mortality. And we know that there's a wide disparity from zone to zone, from urban to rural. which somebody has alluded to even yesterday. And we know the common causes, preterm deliveries and its complications, intrapartum complications, and also infections. We also know that there are low-cost, high-yielding interventions that can be put, into play and reduce neonatal mortality. However, there are quite a lot of limitations, in different areas. And Professor Okolo has said quite a number of them. And with this in our background, then COVID came. COVID came in the year 2019. And we, luckily for us, like Dr. Professor Isiaka has said, we know that the impact of COVID-19, direct impact on on newborn, has not been so much, in the sense that mortality and morbidity has been low. Although we know that when newborns are infected, the severity is also high, increasing hospital admission, neonatal intensive care units, and use of oxygen and mechanical ventilations have been reported. And this is the map for COVID-19. We are aware that the darker the red in this case too, the higher the morbidity, and and we can see that Brazil and some of the developing countries have a lot. And luckily for us, most of the African countries that have the high neonatal mortality are not so badly affected, even though mortality has been reported to be high. So neonates with COVID-19, like Professor Isiaka has said already, that they can be early onset or late onset. Prenatal transmission has been reported, and there's so much still going on about it. We also know that late onset can result into some other issues, like a multi-system inflammatory syndrome, as seen in children, where they have a Kawasaki-like presentation, is not common in newborn, even though it has been reported. I would talk about the impact of COVID on neonatal mortality. It is true that many neonates are not infected, but we know that when they are infected, that could be a problem because we are not prepared. The uninfected neonates of mothers who have been reported, to have increased respiratory rates, distress, and low birth weight. Although studies have also shown that we are not sure which is coming first. Is it because they are born preterm that they have increased respiratory distress, or is it because their mother had COVID infection? That is yet to be decided. We know that a lot is still evolving. And like I said earlier, there were lots of things that have been interventions that have been put in place to reduce neonatal mortality. The family planning, antenatal care, at least 4 times, focus antenatal care, skilled birth attendants, postnatal visits for newborn, postnatal visits for mother, exclusive breastfeeding, and immunization. And we are all aware that, like Dr. Umosu has said earlier on today, we have documents. Most of these have been not only adopted, but adapted to Nigeria. Documents are not our problem. Policies are not our problem in the country. We know where the problem lies. And these interventions have been shown over and over to be efficacious. And we can even see that just giving antibiotics for preterm premature rupture of membrane can reduce incidence of infection by 13 to 47%. And many other things like breastfeeding can reduce neonatal deaths by 55%. So it is well documented that we have some intervention that can impact neonatal mortality. But the problem has been with coverage. We are aware that coverage has been poor. However, in the last 4 years, if you remember, 2009 to 2013, you can see this diagram showing the red. Okay, in the next 4 years, 2014 to 2018, there was a lot of progress, in covering, covering selected interventions, so that the more access people have to it, the more availability of these interventions, the less neonatal deaths. And this was where we were before COVID-19 came in. And we know what happened. The response to COVID-19, because it was, like we said, globally, we were unprepared. Also because it has not been tested in this large scale before. So many things were put in place, forgetting the newborn and their mothers. Like, for example, during pregnancy and antenatal care, one of the things that we did was to reduce routine visits and appointments, and also to exclude low-risk women from face-to-face appointments. Okay, don't come, even if you are sick, don't come, just stay at home. And of course, there are staff shortages which affect care provision too. Some staff themselves got infected, or they have family members to care for, or they were deployed for the maternity section to other parts. You know, they created, in fact, in some hospitals, postnatal wards were converted to COVID wards, you know, so that reduced the space available, and then the number of health workers that were available also. During labor and childbirth too, okay, more women requested delivery at home, and we know that means what that means in Nigeria. In developed countries, home delivery can be very safe, but in our country, home delivery means attendance by unskilled health attendants. You know, so unskilled laborers, informal health sectors had a lot of it, you know, and then of course, sometimes we are the ones who with some labor wards we are closed down totally. I'll show a slide. The next slide should show. Okay, sorry. There, in Kano, in some hospital in March 2020, it was totally closed down. There was no delivery at all, and so those men wanted to deliver cannot deliver. That they had to go look for alternatives to grow, to have their babies. And then, okay, there was reduced or postponed routine home visits. In fact, we hardly do. Home visits is just starting. You know, that postnatal care, you know, for women and their children, it just started. So it hadn't even taken root, and suddenly came COVID. And also, even where we took mothers in, the care content and quality was lower. There was reduced number or complete ban of visitors. Dr. Izaka alluded to that. Nobody was allowed to come in. Some of them, they didn't even want to come themselves. But even when they were around, the husbands of them said, no, you cannot stay with your wife in labor. And normally what we can provide over several, you know, days of visits, we did everything at once because we don't want to have contact with them. And the patients themselves didn't want to come as well. And also, cesarean section were performed on almost all women that either had COVID, either confirmed or suspected, okay? And there was no justification for that, but we just increased the cesarean section rate because we thought that was the best thing to do. We didn't have knowledge of what to do. And of course, we separated mothers from their babies from their newborn, whether the babies were infected, not infected, as long as the mother was suspected to have COVID or she had confirmed COVID, the baby was separated from the mother. Now the baby cannot have kangaroo mother care. Breastfeeding was also not there, which then Professor Izaka just mentioned, you know, and all the benefits of breastfeeding were denied the baby. He said some mothers were left in the hospital and babies were taken home because the newborn services were not available. We also know that there are long-term impacts of neonatal COVID. There are too many things we don't know now. People are wondering whether we could end up with chronic airway inflammation later in life. We don't know, you know. The developmental outcomes, we don't know. But for now, what we do know is that it has impacted a lot of, you know, services. And the evidence on for low and middle income country, you know, with poor NMCH indices, but the current coronavirus pandemic focused approach led to more additional newborn deaths, about 30% increase, because it was like all the services were stopped and diverted to the care of COVID. For example, even the equipment for TB diagnosis were diverted for COVID, you know, diagnosis and the rest. And of course, we know that the incidence of TB has increased in the community. Therefore, it affects our newborn as well. We also know that there was disruption of utilization of services, like I just said too. So it increased maternal mortality. And we all know the impact of maternal mortality even on the newborn care. Before COVID came, you know, there was already, we're all feeling that, okay, we're not doing too well in the progress towards the SDG, particularly 3.2.2, but we were at least moving somewhere. We're trying to see what we can do for 2030. Then suddenly COVID came. And when COVID came, and we already said that 1/3 of this death occurred on the first day of life and 3/4 in the first week. And this is when most of the interventions that came with COVID. Mother should be separated from the baby. So there was no kangaroo mother care. There was no immediate contact, that we put the baby on the mother's chest. No. Even to care for the baby's cord, it was not available. And services were disrupted. Like those who are HIV exposed, there was no development supply because transportation was difficult. Many things were difficult. So these babies were exposed unnecessarily to more dangers. And I just want to give an example of what we saw. The impact of COVID on facility births and admissions in OETAC, where I work, and also in Luth. This was published by Zen White et al. So they said the pre-lockdown total deliveries, they had about January to March 2020, they had about 253. In Ile-Ife, we had 404, okay? And during the lockdown, of course, delivery came down to 121 in Luth. And in the OHS, it came down to 314, And I can tell you that even though we had a higher deliveries, most of them were complicated cases who had been somewhere before, and nobody could help them. They were either at home for 3 days or in the church. Then they were forced to come to our facility. And of course, you know what that means on the babies. The babies were born with asphyxia. So even now, post-lockdown, we are still seeing a lot of babies who are born from outside, who are brought into our ward. So we have about 70% of our outborn admission being due to severe birth asphyxia. I know what that means on the brain of the baby and the brain of the child as well. And then preterm deliveries to also increase, probably because we don't know, the babies were, the mothers, there will have been more intervention if they had come early, premature contractions and the rest, but mothers didn't want to come to the facilities. So they just delivered their babies. So, and I think there was another publication too, which talked about realization of basic MNCH, between 2019 and 2020, okay? And this was published, and included Bangladesh, Nigeria, and some hospitals in Kano, and also in South Africa, okay? And you can see that during ANC, in March, it came down by 28.4%. Remember, we are different phases of the COVID virus at times, so you can understand why Bangladesh had 28.4%. And look at AKTH, in Kano, they suspended delivery totally, no ANC, they just suspended it. In one of the hospitals, 21% decrease. And attendance in family planning clinics, it was, nil, 100% in Bangladesh, 50% in AKTH, and the others, it was not available. And the children vaccination too, about 13.5% in Bangladesh, and in Kano, 50% decrease. So this shows us with the already problems. All the known interventions, vaccination, okay, if you don't have access to it, then you know what means. That means BCG will not be, they wouldn't have BCG, they didn't have hepatitis vaccines, And the family planning attendance, mothers were also at home for a long time with their husbands. So many got pregnant. We are all aware of increased rape. We are also aware that if you get babies too close, that short birth intervals, the impact on the baby, even and on the mother as well. So, and this is what COVID did, because the clinics were closed down and people have to, continue life. And then men and women didn't have anything to do. So they were in the same house. And then, of course, the next thing was to have more babies. So mitigation of the impacts of COVID, the policy of governments and health agencies. One of the things that were that COVID exposed was that we needed to strengthen, the health facilities, because it showed that we're not ready, we're not prepared for disasters, okay, particularly at the state level, okay. Policy of governments, policies are there, but policies have to be implemented, KMC, breastfeeding, and reiterated during the period of need most. This was a time where people needed guidance. People didn't know what to do, so everybody just did what they wanted to do. Emphasis on kangaroo mother care. I'm happy that the Federal Ministry of Health already has a document on KMC for the country, and the risk, okay, of COVID, it showed that if you do KMC, okay, the mortality risk, is reduced by 65 to 630 fold. That's huge. Just putting the baby on the mother's chest, we have been told over and over again that the babies, when they get infected, usually postnatal infections. And mothers who have antibodies also pass the antibodies to their babies. It been shown that mothers who had vaccinated, that the antibodies were also seen in their mother. And vaccine provoked more antibodies, than even the infection itself. So it is safe to put the babies on the mother's chest. Then we need to disseminate information, particularly to the health workers. We need to educate healthcare professionals. We need general measures and precautions that have been said over and over again. I won't go over that. Okay, vaccination of women and pregnant mothers, and maybe newborn in the future. We don't know what it means, but for now, vaccination in pregnant women has been found to be safe. We also have to optimize service delivery settings and platforms. Professor Okola has said that there's inequitable in distribution of services. We know that. In some places, the services are not available at all. And yet in some centers, there are so much of the services that are not being utilized. Establish effective patient flow at all levels too, rapidly redistribute health workforce capacity. I don't know whether that can happen now, because you see, with the COVID itself, developed countries are now tapping into developing countries' manpower. In my hospital, in 1 month, 250 people left, for the advanced country, because the developed country lost a lot of people during the COVID period. They also saw the need for more patients, more health workers. So they are tapping in, they are paying them better. So everybody is going. So now we're talking about the distribution of health costs. Yes, we want to do tax sharing and tax shifting, but many people are going. The government needs to rise up to this occasion and do something fast. We also have to adapt healthcare services, limit contact, safe transport, we say don't carry more than 5 people in a vehicle, but of course, because they have to eat, the drivers just carry the number of people, and people that come to facilities, even on their way, because they cannot afford their own private vehicles, they get infected. Then we also look for innovative way of delivery approaches and the availability of essential supplies. We've said that over and over again. During this COVID, many things went out of, chlorhexidine gel was not available, nevirapine was not available. Those are things that should be available for all the time. And so I think that we had a forecast, but we didn't think of possibility of this pandemic. But I think the COVID should prepare us for a future. We should monitor and review data beyond COVID-19 as well. And then population trust and also knowledge has to be improved, because even now, many people do not want to come to health facilities. They still believe that there's COVID in the health facilities. Okay, so I think most of this slide is talking about almost the same thing, talking about the fact that we increase staff stress, which we know. The staff are worried themselves, they get infected, and then the number of staff in the facilities have reduced. We have to increase the number of staff. Okay, we have to also give them clear protocols, what to do in emergencies and how to go about it. And we also have to encourage the community by doing community awareness programs. Community newborn care has to be also scaled up. So in conclusion, I would like to say that there's high quality maternal and newborn health care. There is essential health services, and it must be sustained to protect the lives and health of our women and children. And we must also strengthen it even during pandemics. These are things that have taken a long time before we got to this stage. We should not let it be eroded by just one pandemic. And I want to say that there's need for equitable distribution of health services. We should also implement National Health Acts. And I said yesterday that the NISOM has a role to play to ensure that the government live up to its promise. When people have to pay out of pocket, then you know what it means. Many people, economic biting now, shops were closed. Even now, many people don't have, many people lost their jobs and they have children to care for, and they will get pregnant, they'll get married. And so how do you do it? We need to play a role in making sure that the government also makes access to health services, free and of quality. Thank you very much for listening. Was that alone? Hello.
Hi.
Hello? Yeah, we can hear you.
Thank you very much. Is Prof on?
Hello.
I've looked for him. I didn't see him.
Okay, talk.
Okay.
Thank you very much, ma'am, for the beautiful presentation. I'm sure the participants have really learned a lot from this beautiful package. We still plead that because we do not have enough time on our side, that we should send out clarifications or comments to the chat box. I'm sure Prof is always available. She will attend to those issues. So the secretary, Dr. Ilo, I don't know what is next now.
Well, next is we're supposed to have okay, Prof is back.
Okay.
We're to go on break now for just 10-20 minutes and then come back and take JNCI presentation and then overview of neonatal jaundice as the last paper. So can we?
Okay. Yep.
Thank the
Prof, just before the break, we have some guests in our midst. There's this group that we've been working with, especially on the national guideline for neonatal care, NEST 360. They just joined us. They're in country for a meeting with the Federal Ministry of Health. So I want to call on the clinical lead of the program, Professor Chinyere Zaka, to gladly introduce them. Professor Zaka, over to you before the break.
Thank you very much. Thank you very much, Dr. Kenneth. Thanks. And kindly permit me, everyone, to utilize this opportunity to appreciate the presence of the Neonatal Essential Solutions and Technology team, which is a Ministry of Health program that's in country. They're actually quarantining. The training is next week with the Federal Ministry of Health, and NISOM has been working very closely. NEST is a program that will support neonatal units with essential technologies and solutions needed to properly care for small and sick newborns. And that is why we're starting with the guidelines, because we did not have these guidelines for secondary and tertiary facilities. If a baby has jaundice, sepsis, asphyxia, we never really had a guideline. We've been working on the essential newborn care, which is mostly at the primary healthcare level. NEST 360 is to provide training and mentorship to clinicians, nurses and biomedical technicians and engineers on how to correctly use, maintain and repair some of these technologies, bubble CPAP, phototherapy, suction machines, pulse oximeters. These have been sent to the pilot centers. And radiant warmers, we need to also strengthen inpatient data and quality improvement. So in our midst at this meeting, we have Professor Liz Molino, who is the lead education team. And she is British. Many of us who know Prof. Liz, foremost neonatologist. She's British, but she's been working in Malawi for decades. She's here in Lagos. She's here in Nigeria. Then we have Engineer Sarah Lagati, who is the NEST 360 Global Health Biomedical Engineer Trainer, who is here with us on this meeting. And we have Emma Thompson, a pediatrician who is working in Malawi. And we have Edith Gachera, who is a neonatal nurse in Kenya. And she's the education lead for NEST 360. So this is all the reorientation and involvement and the moving forward. Nigeria and NISOM has been working closely with NEST, with the Federal Ministry of Health leading and the states for us to make inroads into newborn health in Nigeria. We appreciate their presence and we'll be hearing more about the Newborn Essential Solutions and Technologies program. Thank you very much. And we said that this conference is virtual. We have a lot of people in the diaspora. I'm seeing also the thanks from Professor Tina Slosher, a foremost global lead in neonatal jaundice all over the world. She's in Minnesota. Yesterday, we heard from Professor Rachel, who is Professor Rachel is in Washington. and we have Osayeme, who is in Indiana. So this virtual meeting actually gives us the opportunity to have a very diverse group. Thank you so much, everyone. And I once again appreciate the Next 360 team and everybody for giving us the opportunity. When JNCI presents, you also hear a little more about some of this equipment which are available in country for us to utilize at the secondary and tertiary facilities from NEST and supported by the Federal Ministry of Health. Thank you. Over.
Thank you very much. Prof, we're going to be back at 12 noon. Is that okay, Prof?
Yeah, that's 10 minutes from now. 5 minutes.
10 minutes break.
Oh, it's okay. Yes.
12 noon then.
12 noon. Thank you.
Thank you, Prof.
12. Thank you. Yes.
Good afternoon, all. Hello. Good afternoon, all. My name is Dr. Yedija Adeyemi. I'm the LOC Secretary for the 13th AGSM. I'd like to welcome us all back to the second segment of the third plenary session. My regards and greetings to the chairman of the occasion, Professor Mutar Ibrahim, and his able co-chair, Dr. Iyade Olateju. Now we'll be moving on to the next segment of the program, which is the presentation of technologies by GNCI. GNCI, are you in the house? Hello?
Yes, we are.
Okay. Admin,
Yes,
please kindly give them co-hosting rights so that they can go ahead with their presentation. Thank you.
Oh, let me use. Hello?
Hello?
Hello, can you hear me?
Yes, we can.
Hello?
Yes, we can hear you. We can hear you.
Yes, we can hear you. Hello?
Yes, we can hear you.
We
Okay,
can hear
thank
you. Please go ahead. Admin, please give them co-hosting rights in case they want to control their slides, please. Thank you.
So can I start? Can I start?
Please go ahead, please.
Okay. My name is Brega Tobola, and I'm from GNCI, that's GNC International Limited. And the next few minutes, we'll be looking at innovative NICU solutions, meeting the needs of critical neonatal care in Nigeria. And this is what the content of my presentation will be. And I must also register the fact that the relationship we have with NISOM in addressing issues around this space of neonatal care is going to be stronger going forward. So GNCI is a turnkey medical equipment service company, and we have been in operation for 17 years. And that cuts across Nigeria and some West African countries with 19 global partners currently and then we also have our technical team and clinical application trainers cutting across the country that you can access easily. Our value proposition cuts across all this, and our value chain, apart from intensive care units, cardiology, oncology, project management, hospital planning, a whole lot going on in the healthcare space as regards healthcare and equipment. So these are our partners, and they are well-known partners. They are the well-known OEMs, and that guarantees the fact that you have access to quality equipment and as well as technical support for these equipment and training for all of these equipments. And for our NICU products, neonatal ICU products, we have those 4 partners: Phoenix, Next 360, that has been mentioned several times in previous presentations, Getting K McKay, and B Brown. So for this going straight to the topic again, the data is all over the space there, and so those data were also mentioned in previous presentations. But it's also, those data lets us know that there needs to be an innovative approach in addressing the critical care needs of neonates, and that cuts across issues around jaundice, issues around hypothermia, and also asphyxia. For hypothermic and jaundice newborn care, we have this product you are seeing on the screen, the radiant warmer, the jaundice meter, and the phototherapy machine. Now, the phototherapy machine has an LED bulb, and then that gives you the opportunity of a lifetime hours of 50,000 hours. That is about 9 years. So you don't have to start changing bulbs, and it also gives you therapy within the wavelength that is recommended for therapy. That's 450 wavelengths. And with 1 unit, you can treat as much as 1,042 babies with 1 unit. And you also have the light meter, which is very important in measuring the intensity of the therapy that you're providing. And you could also see that this diagram has the double surface. So you have the over body and the underbody for fast therapy and proper surface area to cover. And the radiant warmer gives it opportunity to have a pre-warmer mode, to also have the manual mode and the auto mode. So it regulates based on the height of the temperature of the baby. And you can find a way of combining these two together in your units. And the jaundice meter is also an opportunity to have quantitative assessment of the patient. So you could also pick up the option of these two and then combine the two together, put them under each other without interfering with the therapy for jaundice and the therapy for hypothermia. Now, for vital respiratory care solution for the newborn patients, these 4 innovative solutions should be something that should be considered. The oxygen concentrator to concentrate air and provide 80 to 95% oxygen concentration FiO2 to the patient from the room air, that is 21%. And this particular one has 8 liters per minute capacity. And you also have the CPAP that provides the continuous positive air pressure and helps to increase the oxygen concentration that the baby breathes in. Then another interesting item here is a suction pump. And this is configured to help in suctioning neonates. So you have the opportunity to set the pressure that is recommended in suctioning for neonates. And also it uses electricity anyway. And so it's more aligned for neonates rather than using the adult suction machine. And so what you have noticed also let you know that the oxygen concentrator has a battery backup, and you have the pulse oximeter here also. So you can have all of these in your space for respiratory support for neonates, all of these items set up this way. And aside that, you also have the more comprehensive nasal CPAP machine, and that is configured to both give the bubble CPAP operation and also give you the flow operation. And this has a very interesting LCD display so that you can see a lot of, you can do a lot of monitoring while the patient is on the CPAP. It also gives the opportunity for apnea alarm and a higher level ventilation compared to the oxygen concentrator. So, and aside that, there's also the opportunity to have a neonatal resuscitation care system like this. This is more of a basic configuration that you have the suction units along with it and the oval shaped bed to give enough access from every angle to the patient. There's the LED display for temperature, for and other parameters you want to use. So another interesting fact also along with this is you can easily get X-ray of the patient without necessarily carrying the patient. So there's an X-ray tray that you just slot in the X-ray sheets, X-ray film. And this one is a comprehensive one, a step up to the previous slide you just saw, and has an inbuilt Massimo pulse oximeter and inbuilt weighing scale. So right there where the patient is, you can do everything with limited touch and access to the patient. You can do the examination while the patient is there. You can go ahead with resuscitation. You can also position your phototherapy machine along with this without interfering with everything you are doing. There's also the CPAP option with this also. And we have our incubators. There's a basic incubator with easy access, storage drawer, and tubing ports. And there is an upgrade of this, which is the INC 200. And this apart from what you have with the basic one, you also have the opportunity to do suctioning with this. You have the opportunity to adjust the height of the incubator. The weight, there's an inbuilt weight scale option also. You can connect your oxygen respiratory support units to this also using the CPAP option also. So it's a more comprehensive incubator, easy access to the patient without any cross infection coming across also. It's also double walled, so it gives the patient the desired atmosphere for care. And these are other options for hypothermia care and also resuscitation. So for the new breeds, you don't need power for this. So it gives you the opportunity to also use your hand to do other things, perform CPR, and also use the equipment with your foot. So it's more like a backup for the others that you have. Embrace infant warmer. It gives the opportunity to keep the baby warm either while transporting, or just if you're in a facility where you don't have enough incubator and then you need to be interchanging from the incubator to the infant warmer. It provides that temperature for about 4 to 6 hours. So you can alternate and use it as a adjunct to the incubator that you have. And also our ventilators from McKay. This is Salvio I. So Salvio I is configured for infants, but you have the opportunity to upgrade this to the adult mode and adult configuration, and also the universal configuration where you can use for both. But the interesting thing about this is the neurally adjusted ventilation that it provides. So it's triggered by electrical activity of the diaphragm, and you have the invasive and non-invasive mode for this also. And you have the auto mode that you can use to do this. So it's a combination of, it will be a combination of what the ventilator provides a support and the effort of the patient also. So it's a very comprehensive and well configured for infants in terms of respiratory support and ventilation. So aside that, there could also be need to deliver large volume of fluids and blood products or parenteral nutrition to patients, or a syringe-based drug delivery. So B. Brown provides the syringe pump and the infusion pump along with the accessories and the lines. So you have the opportunity to use this for a patient even as small as 250 grams weight, and you have different sizes of syringes from 5, 10, 20, and 30, 60 mils. And you can, so this gives you an opportunity to set an accurate delivery, accurate dose and volume of the drug delivery to the patients, and gives you opportunity to do other things while this is being done, and provide safety also apart from the accuracy. So we are not just a product-centric company. We have we have value wherever our equipments are. So we, apart from selling to you, we provide the user and application training. Like I've told you, we are in partnership with all of these OEMs, exclusive partnership. So you have access to all of this. You have access to technical support. You have access to giving you advisory support in terms of your flow plan, instead of your space planning, if you need to manage your space and how to maximize that space. So,
sorry to interject. You have just about 5 more minutes. Thank you.
Yes, sir. So apart from that, there's also, like I think in some of the previous presentations, there were issues that were talked about financing being an issue in this space. So apart from that, we also provide payment solutions along with our partners, these 4 partners. So with this, once you are interested in equipping your facility, you have the opportunity to access as much as 1 billion naira, but you will have to contribute about 20 to 30% of the cost of the equipment. And depending on the bank, you will have an interest rate of ranging between 14 to 16%, and you can pay over 3 to 5 years. That depends on the bank and depends on how much you are getting. So security, which is collateral, the fears of collateral is addressed by the fact that the equipment is the finance equipment is the security. So these are some of the awards to let you know that we have been in this space and been excellent in our operations and delivery. So if you want any of these equipments, these are the very fast presentation, but there are more details. You want us to come to your facility to make a more detailed presentation, you want to make inquiries, you could go to the website or just contact us with these details. All of these equipments are available, and we will give you more information as much as you need. But if I have 2 or 3 minutes more, if there's maybe one question, I could just take that.
Thank you very much, JNCI, for that presentation. Fortunately, you can remain in the wings, and if people ask questions, they can send you chats directly. And at the end of the program, if you're still around, they'll address questions to you directly. At this point, I'd like to hand over the control of this session to the chairman, Professor Mukhtar Ibrahim, and his able co-chair, Dr. Enyade Olateju. Thank you very much. Professor Ibrahim, please. Thank you. No, we have done that. Okay. Professor Mukhtar Ibrahim, please take charge, sir. And I would like now to usher in Professor Tina Stosha to give her presentation. Thank you very much.
Yes, if I could share my screen, that would be helpful.
Admin, please give her co-hosting rights so that she can share her screen. Thank you.
You can do that, Ma.
All right, can you see my slides? Are you able to see my slides?
No.
Yes.
No, not.
Not yet.
There.
Not yet. Yeah. Now, yes.
Yes. Okay. Shall I go ahead or wait? Shall I go ahead?
Yes, now you can start, Ma.
All right. It's quite an honor to be asked to present, and I thank Professor Ibrahim and NISONM for allowing me this opportunity to share about my interest over the past 32 years in Nigeria. And I certainly feel like an honorary Nigerian. And it is quite an honor to be with you today and to talk about neonatal jaundice or hyperbilirubinemia and how we can improve the early recognition, diagnosis, and treatment in low resource settings. I want to thank Dr. Katie Satram, who worked with me on this presentation and is also part of our Stop Kernicterus in Northern Nigeria team. We'll talk about neonatal mortality and some of the regional disparities, the global burden of neonatal jaundice, risk factors, barriers to early recognition and diagnosis and treatment, some of the long-term societal impacts and future steps needed. You've seen this from a lot of folks today and yesterday, but as we know, the neonatal mortality rate is quite high in Nigeria, in the dark green at greater than 35 per 1,000, something we're all working hard to decrease. And as we know, we see these slides all the time where it tells us that prematurity, birth asphyxia, sepsis are leading causes of neonatal mortality in Africa. But as I would like to point out today, something is really missing from this slide, and you'll see it in some tables under other causes. And you see it in this one with jaundice down here as part of others. And I actually think it needs to move out on its own. About 481,000 neonates are affected annually with severe neonatal jaundice. They contribute about 114,000 annual deaths, and that's likely grossly underestimated. Of those who have severe neonatal jaundice, about 63,000 survive with moderate to severe disability. And the incidence of severe neonatal jaundice is 100 times higher in some low middle income regions. About 3% of neonates admitted to hospital have signs of ABE, and kernicterus or acute bilirubin encephalopathy causes neonatal death and childhood death at a frequency that now exceeds neonatal tetanus. This is becoming a little bit older, where we a few years ago looked at the number of cases of severe neonatal jaundice based on clinical markers of acute bilirubin encephalopathy, exchange transfusion, and jaundice-related deaths. And as you see, the WHO African region trumped all the other regions at 668 cases per 10,000 live births. We set out with a group of what I call my young Nigerians. I didn't let the professors and older members of our team participate, and we're getting ready soon to publish this study. And I'm just going to highlight one of the slides with the preliminary data where we went back and looked at the proportion of ABE kernicterus, jaundice-related deaths, and exchange transfusions in hospitalized babies. And we again did a meta-analysis and systematic review. And you can see that once again, the incidence of ABE kernicterus in neonates is substantially higher at 2.74% than in the WHO region of the Americas. And of note, in the African region, all but 2 of the 19 studies were from Nigeria. We're also working with Professor Eziaka and her team to publish some, I think, sad but nonetheless important data looking at neonatal morbidity and mortality at Luth. And no surprise, jaundice is one of the leading causes of neonatal morbidity, along with prematurity, infections, and HIE. But sadly, neonatal mortality still large percent caused from prematurity, as others have highlighted these last couple days, HIE. But I want to point out jaundice. Jaundice is about 11% of the neonatal mortality at Luth, and it actually is higher than the incidence of congenital infections, of infections, and about the same as congenital abnormalities at Luth. And that is data that will also be coming out quite soon. You've heard me talk before about bilirubin neurotoxicity, acute bilirubin encephalopathy, which is now the term for jaundice damage in the first few weeks of life. Most of you have seen it with poor feeding and suck, advancing levels of stupor, hypertonia, opisthotonus, and that irritating high-pitched cry, along with often a kernicteric facies with paralysis of upward gaze, often referred to as sunsetting, eyelid retraction, facial dystonia, which makes these babies appear stunned or anxious, and a disconjugate gaze. Those children who live often progress to what is now, I think, most appropriately called kernicterus spectrum disorder, which can be associated with chorioathetoid palsies, gaze abnormalities, sensorineural hearing loss, and at least with their deciduous teeth, you can see dental enamel dysplasia. We all know that there are regional disparities in neonatal jaundice outcomes. Some of those risks for severe hyperbilirubinemia include G6PD deficiency, ABO, and RH incompatibility, often without routine blood typing or ROGAM, sepsis, lack of early recognition and diagnosis, ineffective treatment, and lack of appropriate neurodevelopmental follow-up and support services. Some of the barriers of early recognition and diagnosis include deliveries at home and or without skilled birth attendants, early discharge from the hospital prior to bilirubin peak, knowledge gaps among families and healthcare providers, lack of screening for risk factors, and no routine bilirubin screening post-discharge. We also have barriers to effective treatment. These include ineffective phototherapy, needing to use our phototherapy units for many babies at one time, and often a lack of an irradiance meter. This is not from Nigeria, it's from a neighboring country, but ineffective phototherapy with 3 fluorescent bulbs and a cot that is not lined with white. We did a short literature search looking at ineffective and unavailable treatments throughout the world. And along with several of our Nigerian colleagues, we looked at the mean irradiance of 76 devices, and we found a mean irradiance of 7.6. And 29 of those 76 devices actually had an irradiance of less than 5. Cameroon, all the units had an irradiance of less than 5. In India, 31% of their 58 units provided unacceptable irradiance. And then, lest the high income countries get too arrogant, in the Netherlands, they have noted that 50% of their devices delivered less than the recommended 10 microwatts per centimeter squared per nanometer. That study led us to look at it in my current home state of Minnesota, and I am happy to report that in Minnesota, our phototherapy wasn't fake, but much of it was not the recommended intensive phototherapy. So we've all got work to do as we look at improving the quality of phototherapy. But the improvements are happening in Africa, as many of you note. In this itty bitty unit in Cameroon, they were able to improve their phototherapy with a combination of things, including new bulbs, a white blanket for the baby to lay on, and moving that fluorescent unit closer, and were able to get their phototherapy up from less than 5 to 23. And a lot's going on in Nigeria and with Nigerians. There's several papers out there from folks you all will recognize. Dr. Amadi looking at overhead and total body phototherapy for severe neonatal jaundice. Professor Abdulakar looking at making locally fabricated phototherapy devices work better. Dr. Diala and his team looking at factors influencing irradiance of locally fabricated phototherapy. And then those of you who work together with me on filtered sunlight phototherapy in both mild and moderate to severe neonatal jaundice, and many, many others of you doing great work on improving phototherapy as we've come to understand how important that is. We're all building on the history of phototherapy. There was a recent article in the Journal of Perinatology where they looked at 60 years of phototherapy for neonatal jaundice and pointed out that from this serendipitous observation by Sister Ward and some laboratory scientists who noted that babies in the sun bleach their skin, and serum in the lab in the sunlight also bleached. From that observation came phototherapy as the standard treatment for neonatal jaundice. And as these doctors pointed out, phototherapy has rescued millions of babies from the tragedy of severe neonatal jaundice, acute bilirubin encephalopathy, and kernicterus spectrum disorders. Some of the newer things that have been highlighted even in our last presentation are LED phototherapy. It certainly offers advantages over fluorescent bulbs, including the fact that it lasts much longer, unlike the fluorescent bulbs, which actually should be changed every 2,000 to 3,000 hours. LED phototherapy can sometimes last anywhere from 3 to 7 years before it begins to lose the radiance. I'm really proud of our Stop Kernicterus in Nigeria team and the folks in Zaria who have developed some pretty amazing LED phototherapy. There's also work telling us that intermediate phototherapy is effective and maybe even better than continuous phototherapy, which makes things like filtered sunlight even more exciting, and also gives us the ability to use limited phototherapy units on more babies by rotating the babies under phototherapy. It is important that we all keep in mind that there are side effects of phototherapy, and they're likely beyond those initially noted, such as hyperthermia and dehydration. There are concerns about oxidative stress from phototherapy, especially in premature neonates. And that is leading most of us in the world of severe neonatal jaundice to increasingly view phototherapy as a drug that should be titrated as we would any other drug based on risk and side effects. So just like you would do intensive chemotherapy for a 25-year-old with leukemia, you're going to do super intense phototherapy for a baby who has acute bilirubin encephalopathy or is nearing exchange, and less aggressive phototherapy for those that are at lower risk of needing an exchange or progressing to acute bilirubin encephalopathy. It's likely that LED phototherapy is less toxic than our older phototherapy. It is also likely that more important is the duration of phototherapy than the height of the irradiance. But those are all things that are undergoing study, and we'll find out as the studies progress. Another thing that I think we all need to be encouraging in our centers is appropriate scoring of our babies with potential acute bilirubin encephalopathy and severe neonatal jaundice. I worked with Professor Owa and several other colleagues on looking at the BIND score, and this was a modified BIND score that attempts to eliminate tetanus as a high BIND score, and also includes the kernicteric facies. And I think by using the BIND score, we can talk the same language as we talk about our babies across the centers and across the country. And then, of course, there's our old friend, G6PD deficiency. It's been almost 3 decades since the World Health Organization recommended universal screening in countries with a male incidence of greater than 5% of G6PD deficiency. We certainly know that Nigeria fits there nicely at 15 to 26% in their males, and yet most centers in Nigeria aren't able to screen for G6PD deficiency. And as we know, there's still too much use of hemolytic agents that remains common in many of the same locations that have a high incidence of G6PD deficiency. That's another gap that we need to work hard to close. There are also blood group screening and low-cost immunoglobulin that's being spearheaded and championed by world experts like Dr. Butani and Zerpersky in countries like Nigeria, with champions from Nigeria, including, of course, your own Professor Angela Okola and many others who are promoting testing for blood typing and RH everywhere babies are born, and folks really working to scale up and validate and implement the use of affordable rhesus immunoglobulin. And although in most locations in Nigeria, RH disease is less important than G6PD, it is absolutely preventable with rhesus immunoglobulin. So congratulations to Professor Okola and all the others who are working on testing and making this available. There's also, as we look at G6PD, some interesting new data that our team working with Dr. Farrak and others have shown that some of the things that a lot of us who have worked in Nigeria as clinicians have seen clinically, but hasn't actually been published in the scientific literature. And that's the effects of things like eucalyptus oil, where in the laboratory, we noticed significantly increased hemolysis in G6PD deficient zebrafish who were exposed to eucalyptus oil. And then for me, a big surprise was mentholated spirits. We don't know yet if the mentholated spirits is clinically significant, i.e. if you use mentholated spirits on the baby's cord, do you get enough of mentholated spirits to actually cause hemolysis in G6PD deficient babies? We don't know that yet. Hopefully we'll get a chance to work together with some of you to see. And the yerba tea actually didn't cause any increased hemolysis in these G6PD deficient zebrafish. But interesting data that we hope to do bench to clinical testing over the coming months to years to see how important those things are. Our group, which included many that are in this audience and others at looking at the effect of empowering mothers or teaching them about neonatal jaundice, what to do and what not to do, made a huge impact in the incidence of acute bilirubin encephalopathy. And you can see once again that in the red were mothers who got no instruction on jaundice, with over 20% of their babies having ABE versus a couple percent in mothers who did get education about jaundice, how to recognize it, how to treat it, what not to do before and after their babies were born. National guidelines and packages are increasingly being shown to be important in both high-income countries and low and middle-income countries. There are currently published guidelines in Ghana, India, Kenya, Malaysia, and South Africa, but I don't believe there are guidelines yet in Nigeria. In Myanmar, a package which included a radiance meter, education, and intensive phototherapy, they were able to decrease their exchange transfusion rate by 69%. One of the things I would like to see happen in Nigeria is Nigerian guidelines. While American Academy of Pediatric guidelines can be helpful in developing your own guidelines, they are not Nigerian or Ugandan or Tanzanian. And the best guidelines are the ones that take into account the risk factors, availability of blood, quality of phototherapy, distance from treatment sites, possibility of follow-up as you work to develop country-specific and maybe even region-specific guidelines for yourself. Future steps needed include, again, the accurate quantification of the problem, something we're working hard with our partners to do, advocacy from international health groups, education of families and healthcare providers, improved diagnosis, simple techniques for improved phototherapy, and focus on preventing disability with the new Sustainable Development Goals. And I have a lot in this room and not in this room to thank for the last 32 years. They include Stop Kernicterus in northern Nigeria, including professors and doctors, including those in this picture, Oguchi, Toma, Farak, Abdullah Kar, and their teams, Dr. Badaro and his team at Obama Professor Owa and Dr. Ogundele in Iliefe, and of course, Professors Bodhi Thomas, Angelo Cola, William Ugala, Chinere Ezeka, Selena Cola, and many, many others that aren't pictured here. I'm grateful to you for all your work in attempting to stop severe neonatal jaundice and its sequelae, for teaching me all I know about severe neonatal jaundice, and for all the work you're doing, and for allowing me to feel like part Nigerian. And I look forward to being a part of working together with you to develop a package approach as we together look forward to a world without kernicterus and kernicterus spectrum disorder. For John Paul, who you see pictured here, who has kernicterus spectrum disorder, and all the children and teens and adults he represents, as we strive to help him and all the children he represents reach their dreams. John Paul wants to be a banker, and I pray someday he will be. And thank you again for allowing me to share with you today. And I'll be happy to answer questions in the chat or via email. Thanks again.
Good to recognize.
Hello.
We'd like to thank Professor Tina Slosher for a very, very interesting and well thought out presentation. Thank you very much, ma'am.
You're welcome.
At this juncture, I want to call on the chairman to take over the chairman and his able co-chair to take over the proceedings of the session. Thank you very much.
Thank you very much. Can we give another round of applause to Professor Tina Slosher? The next part of the conference is questions and answers. Well, of course, running out of time. It's now about 12 minutes to 1. This session is about 17 minutes behind. Nonetheless, we'll give about 15 minutes for questions and answers. So if you wish to ask a question, raise your hand and I'll call upon you to ask a question. And the respective presenters, Professor Ebon Ade Diube, Professor Ezeka, and Professor Tina Slasher, you can all answer to questions posed to you. Thank you. No, they can hear me. So with the COVID, now use this technology.
Is somebody seeing the questions?
Can you check the chat box?
Yes, I don't see any questions for me.
Questions can be posed either orally or through the chat box, please. People are just saying the same thing. Wonderful presentation, blah, blah, blah. See?
Some people have their hands raised.
Oh, there, okay. Let me see. It's raising his hand.
Professor Ebu and
Young,
Young.
quiet, Young. Please ask.
Hello, sir.
Hello.
Chairman, sir. Thank you so much for the opportunity. I want to congratulate Professor Tina Slusher for the wonderful presentation. An old, age-old problem that is coming to the forefront because it's still with us. Just to reiterate the fact that intermittent phototherapy does work. We use intermittent phototherapy, however, with LED phototherapies, not the normal bulbs, on preterm babies. And yes, it does work. We'll do the phototherapy for like 6 hours, and we'll monitor in the side lab. And after that, another 6 hours of rest. And that is very important, particularly in low birth weight babies who will need kangaroo mother care. In some parts of the world, they have a KMC, a phototherapy blanket, which can be put on the back of the baby while the baby is in the mother's chest.
I'll get it first before you do, inshallah.
Mr. Chairman, can you hear me, sir?
Yes, I can hear you.
Okay, then. So we put the phototherapy, some people use a phototherapy blankets, but for KMC, the baby's chest will be on the mother's chest as well. So if you do intermittent phototherapy, it does work, and we hope to report our own findings soon. I discussed that with Tina Slusher some time ago. So thank you very much for the presentation.
Thank you, and thanks for sharing that.
There's this comment, yes.
We have Professor Zaka and Young.
Hello?
Hello. Go ahead with your question.
Thank you very much, Prof. Chair, for the opportunity. And I'll join to thank Professor Tina Slusher for the wonderful, excellent public presentation. about neonatal jaundice in Nigeria and low and middle income countries. Before I talk about jaundice, I'm noting that I have a question on the chat. Two really. One is asking about the presentation. To say that I've already shared my presentation with the admin, and I give permission for that to be shared. Then secondly, I'm seeing Professor Ebono asked about the babies, whether any of them had formula milk and what was our experience. The baby that most of the babies, all the babies were stable from our center, and they had breast milk from their mothers. The baby that was ill, initially we thought we could start with express breast milk, but we had to use formula milk, but we did not use feeding bottle. They used the cup for that baby, and that was fine. So we didn't have any problem with feeding. So I want to add my voice to jaundice. It's a big problem, and to greatly appreciate Professor Tina for the incredible amount of work she's been doing on jaundice to kick Keniteros out of Nigeria. So two items that she mentioned, because one is all about education, then the guidelines, then the point of care, then the radiance meter. To say that, thank you that we are actually articulating jaundice as one of the issues in the guideline to be, for us to have national guideline. We had noted that that was a gap, and that is why this sick and small newborn, working with NISOM is leading on these guidelines. And like the Federal Ministry of Health said, they're almost ready. So thank you, Ma, for letting us know about this gap, which NISOM is spearheading, working with the NEST 360 program. Then you also mentioned about the lack of irradiance meters. We've been talking about irradiance meter, that phototherapy is a drug. You have to measure it where the situation where you keep babies in far away distance, you go to secondary health facilities that we went on assessment. That's what generally obtained. So we really need to speak more about jaundice. It is preventable. The phototherapy is placed so high that actually it said that the health workers are treating themselves, not those babies, because the babies will remain under those bulbs and they will still have bilirubin encephalopathy. So to mention that even on the NISOM chart, people were asking about irradiance meter. To say that the JNCI has these irradiance meters available because they are part of the NEST 360 bundle that is available for sick and small newborns in the country. If it is that you get the Phoenix phototherapy, the one that Mr. Boyega says it lasts for 9 years, the Phoenix phototherapy, the brilliance, actually comes with an inbuilt irradiance meter. So you can measure whether you're giving intensive phototherapy or conventional phototherapy. The NTTS, which is also available, there's a setting on whether you are giving conventional or intensive based on the baby's jaundice serum bilirubin level. So this is it about irradiance meter and the guideline. Then the point of care, really, to maybe because this has come up, to say that within the platform of actually the NEST 360 program, that we're validating a point of care billy-spec machine. We've tested now about 350 babies is being validated in Nigeria, Kenya, and Malawi. This is just to say that it's work in process, and we pray that by the end of this year, we'll have results, because we noted too that when these babies have testing for jaundice, that it takes like 2 days before they can get the results. And by then, of course, the clinical picture of this baby has changed. To thank everyone and to say, let us all work together around this jaundice, but we need to really work at our individual levels and NISOM to take the lead on championing all that we've discussed and what is all currently happening in country for us to reduce this huge burden about neonatal jaundice and bilirubin encephalopathy. Thank you again, Prof. Tina, for this very illuminating lecture. Thank you.
You're most welcome. And I'm putting my email in the chat for anybody who wants to get a hold of me. So I just put it in the chat.
Any other comments and questions? Dr. Zubaida, any question from you? Okay, it's now 1 o'clock, ladies and gentlemen, and we thank you all very much for your participation on this highly entertaining and educative session. I now call to close this session and move on to the next item on the agenda, which is the NISOM AGSM and the elections. So thank you very much, and over to you, the NISOM Secretary. Thanks.
Thank you very much, Professor Mukhtar Ibrahim and Dr. Lateju, for this excellent session that you chaired for us. We're indeed very grateful, and we appreciate you for giving out your time despite your busy schedule. Having concluded this third plenary session, we're now going to call on our president to direct the House on what we'll do next. Mr. President, over to you.
Afternoon. Once again, I want to first of all, I want to appreciate the chairman of the occasion, Professor Mukhtar Ibrahim, and the co-chair. We quite appreciate you. I also want to appreciate all the presenters, starting from Dr. Stella Wosu, the head of Child Health Division, Federal Ministry of Health. We appreciate the presentation. Then to our professors, Professor Angela Okolo, we are quite grateful, Ma, for the wonderful presentation. Professor Professor Chinyere Eziaka, and Professor Ebun Adeji, we quite appreciate your presentations too. JNCI have gone through the innovative solutions for our neonatal units. This is just the first presentation, and we have contacts, how to get in touch with them for us to get more on this, more information on the solutions. To Professor Slasher, she is more, I can say, one of us. We quite appreciate you, Ma, for the presentations. Thank you once again. But before we close, I was told I want to acknowledge the presence of Professor Ralph Oruamabo, our founding father. I was told he's here with us. We appreciate your presence, sir. So, for now, we go on with the next agenda. We go on a break and reconvene at 1:45. We proceed then with the AG Annual General Meeting and elections. So we reconvene at 1:45 p.m. Thank you. Over to LOC.
Thank you very much, Mr. President. Thank you very much, Mr. President. For now, the adjournment as you declared, still holds. So we'll all reconvene at 1:45. Thank you.
Lorraine.
Madam Aleke, just wait for me. I'll bring them to write some requirements for you. I am not the
lament obido nyewe ha tutorial. I keep on saying that this cannot be here. Now complain you don't have this, you don't have that one. You're right.
ndị nke akwa ka hapụ ndị nke ọzọ kwana ha nwee another makeup number 4 ka ha dị ihe ede here depend on the ka ị ghara ịnachi but they have another makeup because I'm sure I have another makeup this one but I hope I'm going to cause
Good afternoon, all.
Afternoon.
Good afternoon.
Hello, afternoon. It's okay. Well, fine, ma. Well done, ma. Thank you for the support. Thank you, ma. We just to inform you, we agreed you and Professor Iredi will be the
Good afternoon, all.
Good
We
afternoon.
are 50. Yeah, good afternoon. We are 56 now. We'll start in the next 6 minutes. By 2 o'clock, the AGM will start. Just waiting for the president to put in some finishing touches. 2 o'clock, just give us some time. Thank you very much.
Yes. Ah. Okay.
Good afternoon, all.
Good afternoon.
I don't know if you can hear me. Okay,
Yes.
we are 5 in the house now. So I will gladly hand over to the president for the proceeding of the meeting. Thank you.
Afternoon.
Good afternoon.
Dr. Ilo, can we share the
Good afternoon.
afternoon? Can we take a minute to pray according to our individual faith before we start the meeting? Amen. Can we have the agenda?
Hello? Yes. Yes.
I'm trying
Dr.
to.
Okay, okay.
Push, okay.
So that's the agenda for the meeting. We have done number 1, opening prayer, adoption of agenda. Can we adopt the agenda for the meeting? We can unmute ourselves and adopt the agenda.
Yeah, I and Nkolo move for adoption of the agenda.
Okay. Professor Okolo.
Yes, and I
has moved. Okay, go ahead.
Karim, I read the second the recommended adoption.
Okay, thank you, sir and ma. Any apologies? Dr. Ilo, any apologies?
None.
Okay. Number 4, necrologists. Necrologists, we know that we lost 2 of our board of trustee members, emeritus professors, Adeoye Adeni of Ilorin and Emeritus Professor Jonathan Azubike of Enugu. Can we take a minute silence in honor of the deceased? Pray for their souls to rest in peace. Amen.
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 So number 5, opening remarks. I want to appreciate all of us, especially our teachers and elders who have been with us. In fact, who have been online before most of us even joined for this meeting yesterday and today. We quite appreciate the support we received towards the success of this annual general scientific meeting. We also appreciate the LOC for such a wonderful organization of the conference. Thank you very much. For the members, we also appreciate the support. Unlike in those days, even for physical meetings, when we have barely 20, 25 attending the meeting, this time around, yesterday during the opening ceremony, we had more than 150. This is quite remarkable. We quite appreciate each and every one of you for this support. Thank you. Number 6, reading of the minutes of the annual general scientific meeting, Kaduna Zaria 2019. Remember last year, we were unable to convene for our annual general meeting because of the COVID-19 pandemic. So this is the second annual general meeting of this executive committee. So we take the minutes of the meeting. The secretary.
I don't know if you can see my screen.
Yes, we can see.
Yes, we can. All right, so I'm going to take the minutes of the 12th annual general scientific meeting held on Friday, 28th June 2019 at the Computer Dialogue Village, Kaduna. The meeting was recorded by the Assistant Secretary, Dr. Taslim Lawal. The meeting was called to order with an opening prayer at about 2:45 p.m. The agenda was displayed and was adopted by a motion moved by Dr. Ben Onampa and was seconded by Dr. Adeyemi Oyedeji. In that meeting, there were no apologies and no necrologies. In the opening remark, the president thanked all the members for attending and for their support. especially those who came around for the pre-conference and had gone home. He also appreciated all those that assisted with fundraising. The reading of minutes of last AGSM that was held in Biruni Kebbi in 2018 was read by the secretary. Corrections were effected. The minutes were adopted as amended by a motion moved by Dr. Ben, now Professor Ben Onankwa, and seconded by Dr. Abdulkadir, now Professor Abdulkadir. Matters that arose from the minutes included a NISOM constitution. It was reported that input from members had been collated and corrections had been effected. And the corrected version was also circulated, and time frame was given for people to make further correction. And there were no further correction. And in that meeting, we termed that the constitution has now come into power. The website was also discussed, and we reported that the payments were previously non-regular, but as at that meeting, were up to date, and the issues of access has also been addressed. NISOM Journal, the Nigerian Journal of Perinatal and Neonatal Care, also came up at the meeting. After deliberations on the attempt to start the journal, the House decided to appoint Dr. Lamidi Audu as the editor-in-chief and was given the task to co-opt members to work with him, including the previous editorial staff. He was also mandated to present the maiden issue in the next NISOM AGSM. We also talked about the NPDSR, where it was reported that NISOM participated in the production of a revised protocol in conjunction with FMOH and other stakeholders. These were the matters that arose from the minutes of the AGM that was held in Kebbi in 2018. We went on to discuss the president's report, which was presented by Mustafa, where he highlighted the activities that had happened under his watch. At the end, he received a clapping ovation, and there were no discussion based on our constitution. The secretary's report followed. Comments that followed on the secondary reports included Professor Kolo, who commended NISOM for the MCSP PAN NISOM program and spoke on the need to scale up these interventions to other states while sustaining the gains that were made in Ebonyi and Kogi states. She also suggested that NISOM should approach other agencies, including UNICEF, Save the Children, and other development partners to see how this can be achieved. Dr. Tongo also suggested that we get the Midwifery Council to be involved in ENCC, and if possible, include the course content in their curriculum. Celebration of the world event. Professor Kolo suggested that NISOM should have a broad plan across the country for the celebration of these special days, especially the World Breastfeeding Day, including seminars, symposia, media chats, and more. This was also reiterated by others, including Professor Onanikunlo. There was a suggestion that NISOM should champion the setting up of a lactation management course. This was suggested by Dr. Kemi Tongo. After the comment of the Treasurer's report, on the Secretary's report, came the Treasurer's report. This was presented by the Treasurer, Dr. Amsa Marami. The comments that came afterwards included Dr. Ben Onankwa, who suggested that we should invest 80% of our savings. Professor Lowe also suggested that NISOM going forward should always have an annual budget and a costed work plan to enable us function better. We now went to the financial updates. It was reported that many of our members are not financially up to date even at that meeting. I think it was only about 54 out of 158 that were financially up to date. Members were encouraged to pay their dues regularly. Hopefully in this meeting, we'll see if this clarion call was heeded to. There was also the reading of the communique, which was read by the secretary of the drafting committee. The review that was made by members were incorporated. We also discussed the NISOM annual general scientific meetings. Bayelsa was given the hosting right, or took the hosting right of 2020, which due to the COVID pandemic was not done until this year, 2021. So in this meeting, we will decide if we will still continue in this order. Asaba was to host 2021, Lagos 2022. We revisited the NISOM standing committee, where it was said that there was a need for us to have standing committees that will help the association function optimally. And the following committees were formed and populated. The Journal Committee, Dr. Laudamidi was the editor-in-chief. For the Neonatal Respiratory Committee, Professor Kolo, Dr. Kongpo, Dr. Deji, and Dr. Audu. For the Neonatal Guideline Committee, we nominated Professor Zaka, Dr. Muktayola, Professor Bokadil, and Dr. Kenneth Pilo. For the Neonatal Nutrition Committee, Dr. Kemi Tongo, Dr. Nyane Kundolowo, Dr. Laila Hassan, and Dr. Ben Onampa. Then for the Essential Newborn Care Course Committee, we had Dr. Patricia Medupi, Dr. Bumneme Ezanosike, and Dr. Bose Toma. And the chairmen of these committees were given the mandate to get more members to join them as the need arises. In this meeting also, we discussed the terms of reference for zonal coordinators. This was presented to the House and it was adopted. We also discussed the bag mask project / initiative, whose aim is to ensure that every health facility where delivery takes place has at least one functional bag and mask device and a penguin suction. It was noted with utmost display that some facilities in this, even those in the cities that are close to the tertiary hospitals, that they do not have functional bag and mask device. So it was agreed that NISOM should lead this campaign and that no training or ENCC or NRT should be carried out without the provision for handing over bag, mask device, and penguin suction to the facilities where the participants for the training will be drawn. It was suggested that we also add the provision of feeding cups even to these projects, and if possible, approach local plastic manufacturing companies to produce nifty cup for us, as that is not readily available in country. AOB, 2 AOB was discussed. One was the need to involve all parts of the country in NISOM activity. And the second was the need for NISOM to have a program manager whose duty will be to work in the areas of interface between the development partners and even grant writing. We discussed this, but conclusion was not made that this could even be either on a permanent or part-time basis. Closing prayer and adjournment. Having exhausted all the points that were raised in the agenda, the president thanked all that have participated and called for motion for adjournment for the meeting, which was moved by Dr. Lillian Ekwem and seconded by Dr. Echinkonye. The meeting came to a close at about 17:11 hours. Thank you very much.
Thank you, Dr. Ilo, for the presentation of the minutes. We take matters arising from the minutes of the meeting. But before I do that, because of the COVID pandemic, a large part of the issues could not be addressed. So we start with for the Constitution. At that meeting, that has been reviewed and the agreements were put in place. So it's just for us to circulate to ensure that we have the Constitution and circulate to members so that members will have the Constitution with them and can make use of it during meetings. And that is what I think the Secretariat should try and make that available so that members will have that and know what is entailed in the constitutions. For the website, NISONM website presently is up and running. We have been receiving the amount that we need to pay annually.
Hello, can you hear the president?
We have been paying. For the Nigerian Journal of Perinatal and Neonatal Care, we appreciate the NISONM members during the AGSM for allowing the editorial team to proceed. And the outcome of this is what we saw yesterday, the maiden edition, which was launched during the opening ceremony. So it's just for us to continue to support the editorial team by providing them articles so that more and more editions of this journal will be up and running. That way, we will conclude the other aspects of registration, having published many more editions. For the MPDSR and other collaborations, we still continue having collaborations with between the society and the Federal Ministry of Health. The MPDSR is just one of many. During the period, the last 2 years, we have had the neonatal treatment guidelines, which is ready now, just awaiting launching by the Honorable Minister. For the Midwifery Council, we have had contact. We took an advocacy visit to the Registrar of Midwifery, Nursing and Midwifery Council of Nigeria. Some of us in the ESCO went and we discussed a lot of issues, including the inclusion of some of these programs into the curriculum of the schools of nursing and midwifery. And by the time we went there, they were actually reviewing some of their curriculum. So that came in handy, and the registrar asked us to submit documents so that can be considered during the curricular upgrading of the curriculum, which we did. We also discussed the issue of having neonatal nursing program up and running in the country. We have been discussing this within us and with the Federal Ministry. So we also discussed that with the Registrar of the Nursing and Midwifery Council. And they are also ready to support. In fact, they have already planned plan of establishing neonatal nursing programs and moving them to universities.
Hello,
just
Prof.
working on. Yes.
Hello, Prof. I just received a point of order.
Okay.
That we have not adopted the minutes.
Okay.
That we should adopt the minutes before
discussion.
We'll make corrections before we discuss.
Okay.
Sorry, Prof.
It's okay. So can we adopt the minutes as presented to us?
Professor Zaka is raising her hand.
Yes. Go ahead, Professor Zaka.
Okay, but yeah, before the adoption, thank you very much, Prof. Mustafa, and thanks, Kenneth, the fatigable secretary, for the very comprehensive presentation. Because I just want to note on two key things. In apologies, I know I had an apology for that meeting. If that can be reflected, because I know I was out of the country at that time. Then secondly, I'm seeing Lagos to host NISOM. Did you people agree to this in absentia? Because I think we'll still put a query to it so that
Prof, I thought you was going to. If you move the motion, we need somebody to second you before we discuss.
Okay, I'm so sorry. Then let me okay, I adopt the presentation from the secretary, please. So sorry, thanks.
But please, he was not present. Point of
yes. You
are not present.
But you cannot adopt.
I thought.
Okay.
Sorry, through the chair. I thought President said we'll note the corrections before the adoption. Or
no.
Is it there?
No. We adopt first.
Please let us be streamlined. Let us streamline it. I was following President Mustafa's. He said let us make corrections and then over, please. Thank you.
Dr. Lamidi's hand is up.
Okay. Yes, I move for the adoption of the minutes of the meeting as presented.
Okay.
Okay.
Then
Dr. Fajolu.
I, Dr. Reti Fajolu, move to second the minutes as presented. Thank you.
Thank you. So the minutes have been adopted. We continue with the discussion.
Okay. Thank
Matters
you very
arising
much.
from the minutes.
Thank you.
Okay.
So my 2 points are noted. One is to include the name in apologies, because I know I had a profuse apology at that point. And then the
that has
hosting.
been noted, ma'am.
Thank you. Yeah, the hosting.
It will be included.
Do we still put query
the hosting
to
will
it?
discuss
Yes,
that.
so, exactly.
Later.
Thank you so much. All right. Thank you so much. Over.
Okay. So for still on the next is celebration of events. I think between the last AGSM and today, better celebration of events have taken place. The World Prematurity Week, Breastfeeding Week have all been celebrated, and pictures were some were published and some were put on our WhatsApp platforms. The standing committees, really for the standing committees, for the journal committee, I think they have worked tirelessly during the period, and we have seen the output. But for the other committees, probably because of the COVID-19 pandemic, a lot could not be done. So we still sustain these committees and maybe reinvigorate them so that they work through the mandates given to them. For the Back and Mask initiative, we actually discussed this with at the level of the Federal Ministry of Health and agreed that no more trainings should never again be conducted without leaving the bag and mask after the training with the people trained. And for the trainings that I know happened after that, we have had bag and mask. Either one of them we collected from the stock that we have left from the previous trainings done by PAN and NISONM. So we collected some and we distributed these after the training. And I know subsequently too, many other trainings, these were provided after the training. I think that's for the matters arising. That's for the matters arising. So if there are no, we move on with the next item. The agenda. Dr. Ilo, can we see the agenda?
It's on, it has come
okay.
up.
Make it larger. Is bloat.
Okay, but what is following is the president's report after matters arising.
Okay. So can I share my screen?
Go ahead and share, Prof.
Okay. The Nigerian Society of Neonatal Medicine, Bayelsa 2021, the President's address at the AGM. I welcome you all to our 13th annual general meeting, tagged Bayelsa 2021.
We're yet to see your screen, Prof.
Sorry, the network went off. This is the second AGSM of the current NISOM Executive Council that were inaugurated at our 11th annual general meeting in Cape B. Sorry, I'm having network challenge. Can you hear me now?
Yes, we can.
Okay.
You're back.
Okay. The theme for this conference, universal health coverage for newborn care, and sub-theme, enhancing and achieving sustainable quality of care for newborn, are quite apt to address current challenges, especially asphyxia, newborn sepsis, prematurity, and neonatal jaundice. I'm glad to state that our society has gained momentous strides and has continued to make remarkable, sustained progress. Highlight of some of our activities include partnerships with Federal Ministry of Health, development partners, and international collaborators. Partnership with the Federal Ministry of Health and development partners, the Child Health Technical Working Group, and the Newborn National Subcommittee were reconstituted with new mandates given to help improve outcome. NISOM participated in various national newborn meetings, including on the production of the National Neonatal Treatment Guidelines. This guideline is ready for launching by the Honorable Minister of Health. We also participated in the verbal and social autopsy study from inception to the end, that is dissemination, in collaboration with the Federal Ministry of Health, the Population Commission, and other development partners. NISOM also participated actively in the NEST 360 program, which is designed to produce neonatal equipments, which have actually been produced that are easy to maintain, and also bringing together the neonatologists and biomedical engineers together. We are also working in collaboration with the Federal Ministry of Health and UNICEF towards community newborn care. That is in the pipeline. Also, another partnership NISOM, between NISOM and Niger State government and neonatal concerns in the form of neonatal support course, handling your tools and your neonates, a 5-module course, which started early in 2020, but we were unable to join due to the COVID-19 pandemic. We also had an advocacy visit to the Registrar, Nursing and Midwifery Council of Nigeria, working with the council towards the establishment of schools of neonatal nursing. Looking at international collaborations, NISOM has had several online meetings with Council of International Neonatal Nurses, working with them towards their support in establishment of neonatal nursing programs in the country. The Council of International Neonatal Nurses has actually been working with other African countries and has established some neonatal nursing training programs in some of our African countries. So we are also working to see that is put in place for Nigeria. Also working towards the getting of grants and collaborative work with neonatal units across the country. This is a collaboration between the International Foundation Against Infectious Diseases on one hand, and NISOM and Pediatric Society of Infectious Diseases on the other hand. So this is still in progress. NISOM is also in partnership with a group of neonatologists and biomedical engineers across the world under the program NEST 360, working on technology solutions towards the care of the newborn. This is in collaboration with the Federal Ministry of Health. Countries involved here are the US and UK, Malawi, Kenya, Tanzania, and Nigeria for now. There is plan for more. We got an invitation for a collaboration from the international. So NISOM recently got an invitation for collaboration from the International Pediatric and Strabismus Council through the Stop Infant Blindness in Africa project. This we are working on, and my belief is this will be useful to our units across the country. Other activities, the Nigerian Journal of Perinatal and Neonatal Care, the maiden edition is out. We appreciate the editorial team and our members for the support towards actualization of the journal. The society has grown significantly over the years, with members showing more interest in our activities than what it used to be. Attendance on day one of this particular virtual meeting was more than 150, unlike previously 20 to 25 in our early days. Lastly, I want to greatly thank all our trustees, the entire executive council members, the Bayelsa LOC, and all NISOM members for your great encouragement and unflinching support. I thank you all. Thank you. So that's the President's address. Next on the agenda is the Secretary's address, right?
Yes.
Okay. So we take the Secretary's address.
Just a minute, I'm having issues. Whoa. Wow. Sorry, I've tried to share my slide. It seems not to be working. So maybe just please do listen to me. I'm sorry for that. Well, and the Secretary's report presented by the Secretary at the annual general meeting of Nigerian Society of Neonatal Medicine held being hosted by Bayelsa State in 2021, a virtual meeting. With utmost pleasure, I humbly present to you the NISOM Secretary's report for 2019 till date. I'll start with the membership. The membership of the association at present is about 200 members, both the trustees, life members, ordinary members, associate members, and trainee members. Of these, only 59 members are up to date with their dues. In terms of communications, our major means of communication from the Secretariat had been via the email, which is nisom.nigeria@gmail.com. We recently formed a WhatsApp platform, which we're using for this conference, and we hope to maintain after this conference to be one of our means of communication. We also have our website and the newsletter. Partnership, this president has gone ahead to mention all the partnerships that we have, both with PAN, NEST 360, the Federal Ministry of Health, development agencies. But I want to mention the partnership between Thompson and Grace. This partnership was towards provision of affordable surfactant, easier method of surfactant administration, and support for training, especially neonatal respiratory support. The last of such training held in Uyo in 4th March 2020. More trainings are being planned as many regions have indicated interest. Sadly, the MD CEO of this company, Mr. Isaac Thomas, passed on last year during the COVID era. We pray that his soul will continue to rest in the bosom of the Almighty God. Amen. NISOM featured in his burial. We sent our goodwill message, and we also sent representative to the burial. The next thing I want to talk about was the celebration of the world events, which the president has also talked about. During this year's World Prematurity Day, we went ahead to develop a jingle that was translated in 3 common Nigerian languages, major Nigerian languages that were aired. There were issues with it, but we hope that the incoming administration will build on it and for it to be a regular thing with our association, because honestly, when you communicate with people in several forms, things are driven down better. Membership directory. We are in the process of concluding our membership directory. This will be circulated for your input soon. Thank you all for giving me opportunity to serve. God bless you all and bless our association. Dr. Kenneth Quilo, NISOM Secretary. Thank you. Hello? Mr. President, I'm through.
Presidente.
Hope I was heard.
Yes, we heard you.
Yes,
Mr.
sir, you
President.
were heard.
Well done,
Okay.
well done. Dr. Elo, well done.
Thank you, ma'am.
Sorry, I was muted. So we discussed the secretary's report. Comments, questions. If there are no comments, can we move on?
I move for the adoption of the report.
Okay, can we adopt the secretary's report?
Someone moved just now. I should give his name.
I think Professor Moborale has moved, and Professor Zaka is seconding.
Okay.
Thank you.
We can now discuss.
Okay. Thank you. Yes, Professor Ezeaka.
Sorry, I said I just seconded the report. Yes, I'm not making comments. Thanks. But okay, since you called me up, thank you so much, President. I was actually thinking when Kenneth mentioned the secretary mentioned the jingles in different languages. I said probably a newborn discharge guide that we had developed and even translated it to 3 different languages. I think we should resurrect, push it, the incoming ESCO should push this agenda, even at the backdrop of the lecture Professor Tina gave today, because that newborn discharge guide gives us the opportunity to speak to mothers at the primary healthcare level, which is a pictorial information and counseling document, guide, leaflet, so that when they go home, they're able to know what to do when their babies develop danger sign. And that leaflet really articulated jaundice about then going back to the primary health care center within the 3 to 5 of delivery so that their babies will be checked for jaundice. So maybe we can take these promotional documents and jingles together and present it again to the Federal Ministry of Health, the Health Promotion Units, because currently they had been adopted by the ministry, but they are not in use. The next group came and the next person in the health promotion came and somehow they've not been using it. Thank you. Over.
Thank you, Prof. We take note of that and pass to the incoming ESCO to work on that.
Incoming ESCO.
Recording in progress.
Yes, ma'am. Can we take more comments and questions?
There's a suggestion in the charts. Somebody is saying, will Telegram group not be better than WhatsApp group for communication?
I think we are very happy with the WhatsApp group.
Okay.
Don't move us to Telegram. Thank you.
I think the number is not so much. It's still, we can still be accommodated on the WhatsApp. Any more comments? Okay. If there are no more comments, can we move on?
Okay. The next point in the agenda is the treasurer's report.
Okay. The treasurer, can we take your reports?
Yes, good afternoon, everyone.
Dr. Hamza.
Yes, can you hear me?
Yes.
Okay, great. Can
Yeah,
I be
clear, loud and clear.
to share my screen? Just a moment.
Share your slides, please.
Yeah,
What does he share slide do?
okay, I think this should be.
Thank you.
Thank you.
Okay, great. Okay. Okay, good afternoon, everyone.
Good afternoon.
We didn't have.
Good afternoon.
Thank you. Okay, being that we didn't have the opportunity of holding an AGM last year, I actually have 2 audit reports to present. So I'll go through them swiftly. I'll start with the financial statement for the year that ended on the 31st of May, 2020. This was audited by Fabomi Olani Pekun & Co. These are their details. And these are just the preliminary details about the accounting and financial status of the association. So I'll go straight to the report. So distinguished members, I'm delighted to welcome you to the 13th annual general meeting of the Nigerian Society of Neonatal Medicine. At present, the association has 3 accounts comprising 1 current account and 2 domiciliary accounts with Guarantee Trust Bank. We also have an investment in ARM Money Market Fund, which helps us to increase our surplus over the years. Below are the highlights of the 2020 financial statements. In the GTB Naira account, the income we raised was 16,848,335 Naira, and we expended 9,876,386 Naira, leaving us with a surplus of 6,971,949 Naira. We were able to secure a grant from AbbVie Pharmaceuticals, yes, to the tune of $3,700. So that moved our dollar account from 0 to having a balance of $3,720. Our ARM investment, the total amount as at then was amounted to 19,014,210 Naira. We had accrued an interest of 239,460 Naira. And at the end of the financial year, it was totally, our assets were valued at 19,253,670 Naira. So the society recorded a total surplus of 6,971,949 Naira, owing to internal efficiency and controls coupled with diligent cost management. Assets with ARM money market stood at this rate, and that is an increase of about 2 million Naira from the preceding year's result. We appreciate the sponsorship that we got from our various donors and pray that the Almighty God to replenish their endeavors, because we had quite a number of organizations that supported us towards the AGSM, the 12th AGSM that held in Kaduna, Zaria. This is the report of the independent auditors to the members of the Nigerian Society of Neonatal Medicine, with the seal that has been applied and endorsed. Okay, so I'll quickly just go through the details of the income and expenditure. During that year, we raised 780,000 naira from our registration for the AGSM, and 370,000 from registration for the respiratory support workshop, and only a small, pitiful amount of 355,000 as annual dues, while we got almost 90 million from donations and exhibitions. We also got 216,000 as hotel accommodation cash advance from one of our partner organizations. We raised 55,000 naira from induction fee of new members, and then we also got 40,000 naira from other minor sources. And then we had the interest that had accrued on the ARM investment. So the total income for that year was 10,973,560 naira. Our expenditures were mainly for supporting the modified ENCC workshop and the respiratory support workshop. And then there were general administrative expenses. There were advertisement, publicity, and entertainment that took place during the AGSM. And there were refreshment and feeding. This included the tea breaks and the lunch, and as well as the dinner. We had to pay for security during the AGSM, and then transportation of members during the year, including the AGSM. There were some printing expenses. There was a hotel accommodation of Expo and the LOC members. And then there were service charges from the bank. So in essence, our expenditure stood at 9,876,386 naira. So we had a total surplus of 6,971 naira 949 at the end of that financial year. The ARM market fund is as stated, and so by the time you add what we had in ARM as 19 million plus the 6 million balance at the end of the year in the GTB account, this totaled our assets at 25,746,700 naira. However, we still have those long-term non-current liabilities that we inherited over the years. And as I explained earlier, that we got the donation by Abbey Pharmaceuticals, and then that raised our domiciliary dollar account to a balance of $3,721. So, but at the end of that financial year, we had some pending liabilities, which included the balance of payment for the creation of the NISONM journal website. We had just paid some made part payment to the vendor, and then we still had one member that we had not reimbursed, paid his facilitation fees for the modified ENCC course. And then we had the auditor's fee as well. And this is just highlighting the ARM investment, how we have fared over the years. So as at the financial year that ended in May 2017, the value was 10 million. Then this accrued over the years to 19,014,211 naira at the end of the 2020 financial year. So the recommendation then was for members to always be in good financial standing with the society. Okay, so I think I'll just quickly now go on to this year's reports. Just a moment. Okay. Yes, I think. Okay. So for this year, our accounts were again audited by Fabumib Olanipekunam Co. And this report was concluded on the 22nd of June 2021. And this again are just the preambles of the accounting process. Okay, all right, so yeah, so this is the current report for the period 1st June 2020 to 31st May 2021, which I'm presenting virtually at the 13th AGSM Bayelsa 2021. The association still has the 3 accounts, the current account, Naira account, and the 2 domiciliary accounts with Guarantee Trust Bank PLC. And we still have the investment with ARM Money Market. And this has helped to increase our surplus over the years. And below are the highlights of the 2020 financial statements. So in this immediate preceding year, our total income was 7,031,409 Naira, and we expended only 1,105,571 Naira. And so we had a surplus of 5,925,838 Naira. Okay, maybe when I go through the expenditures, I'll explain it. And our dollar domiciliary account still stood as what it was in the preceding year. Okay. Our ARM money markets had accrued.
Sorry, we are not seeing the reports.
Oh, sorry, really? Oh,
yes.
Dear. Oh, okay, so just a moment, maybe because I see.
Yeah, we are seeing a diagram only.
You are seeing what?
Diagram.
Oh, wow, sorry, just a moment then.
An oblong diagram.
Oh, wow.
Yes, sir.
Okay, maybe maybe I have to share. Just a minute. Let's hold on, let me find it. Can you see it now?
Not yet.
Not yet. Oh.
Oh dear. Okay, let me stop sharing and then start afresh. Am I still enabled to share? Yes, I am.
Not yet seeing your screen.
All right, just a moment now.
It's on now.
Waiting for it to come up.
No, this is the old, this is last year's own. Is it on now?
You can't see a thing yet, but there's
Not,
some
we can see your screen, but it's not opening yet.
Okay.
Okay, just a moment. Okay, oh dear.
It's showing the folder where you have it.
Okay, so let me. I think I'm good now, right?
Yes, you are.
Yes.
Yes, we are seeing your
All right.
screen now.
My apologies. I think it's because there were two reports. So, okay, maybe let me just quickly go through it again from the beginning. Okay, so this year, as I said earlier, we still have the three accounts, the Naira account and our two domiciliary accounts. And we still have our investment with the ARM fund. And in the immediate preceding financial year, our total income was 7,031,409 Naira, and we expended 1,105,570.
Sorry, we can't hear you now. You are mute. Or is it only me?
It's not only you, sir.
Same here.
No.
Appears as if she's been locked out. Mr. President, the treasurer is no longer on. So maybe she's been locked out. Sir.
Yeah. Well, we don't even lock people out. Maybe it was her network. Maybe let's just give her some time to see if she will come back.
Yes. I mean, it's the internet, not you.
Yeah.
I'm so sorry, my network.
Okay, she's back.
Yes, I'm back. I'm so sorry about that. Let me go back to it again. Okay, I think this is where you lost me. Yes, so I said our ARM investment went up to 90,763,058 Naira. So we're able to record a surplus of 5,925,838 Naira. And the ARM investment had an increase of 509,388 Naira from the preceding year's figure. So this is the report of the independent auditors with the seal applied and endorsed on the 22nd of June, 2021. Okay, so now I'll just go through the breakdown of the income and expenditure. So in the preceding year, we're only able to raise 150,000 Naira as from members as annual dues, and only 20,000 Naira as registration fee. So that was a total of 170,000 Naira. And our ARM investment for the 3 quarters was 128,920 Naira. Our opening balance was 6,732,489 Naira from the preceding year. So by the time you add this, our total income for the year was 7,031,409 Naira. Our expenditures were very minimal in the preceding year. for obvious reasons, since we didn't have an AGSM, we spent only 55,571 naira for administrative expenses. 50,000 was the auditor's fee, 5,000 was for his transport and the accounting records, and then 571,000 naira was the were the bank charges. We paid the balance of the NISOM Journal website, which was 50,000 naira, and then we gave the Bayelsa LOC 1 million naira as seed money. So really, in essence, all that was spent was 105,000 naira. And so we ended up with a surplus of 5,925,838 naira at the end of this financial year. And because we didn't have an AGSM, we're not able to raise funds from registration for the conference, and neither will be able to get donation from our usual partners and sponsors. So coming to the ARM investment, our current standing is 19,634,138 naira. And by the time you add the 5,796,918 in the GTB naira account, it gives us a total asset of 25,431,056 naira. And we still have those long-term non-current liabilities. And we have some payables, outstanding payables, 240,000 naira, but these have all been cleared as at date. Domiciliary accounts still stood at $3,721. And this is just further breaking down what I had explained earlier, the annual dues and the registration that totaled 170,000, and then the expenditures, the auditor's fee, transport and accounting records, and then the bank commissions, and then the payment for the creation of the NISOM Journal website.
I hear you.
Hello, we cannot hear you. Treasurer, we can't hear you. Hello? Hello?
I'm so sorry, can you hear me now?
Oh, yes, we can.
Okay, so sorry. Yes, so I was just going through the outstanding liabilities, which I said have all been cleared as at date. And maybe just to make a note about the subsequent events that took place after outside the accounting period that ended on the 31st of May, 2021, just to say that within the period of 1st of June to the 22nd of June, we had raised annual dues and registration fees amounting to 1,070,000 naira. In fact, as at today, the figures stands at 1,310,000 naira and registration fee of 60,000 naira. So totaling 1,370,000 naira was raised within the last 3 weeks from annual dues and registration fees. And then we got a donation from Niger Delta University Teaching Hospital of 300,000 naira. This took place outside this accounting period and will be captured in next year's accounting process. So I want to just appeal to members to please continue to subscribe and pay all their financial obligations as at when due. We shouldn't wait for the election year before we clear our backlog. This, I was able to raise over 1 million in the last 3 weeks, all because the elections for this year are going to take place virtually, and we're going to have a voters list, and that was really what prompted members to pay their dues. So I want to appreciate everyone for the support and the opportunity given to me to be of service to our esteemed society as the treasurer over the last 3 years. I give glory to the Almighty for the success that we have recorded these past 3 years. Thank you very much. If there are any questions or comments, I'll be happy to take them.
Well done, the treasurer, for this beautiful presentation. We will be adopting the presentation. Okay. Dr. Aisha. I can see Dr. Aisha's hand up. Go ahead.
Sorry, it's Dr. Zubaida. It's a mistake. I'm using Aisha's. Yeah, I'm using Aisha's computer. Sorry.
Go ahead, Dr. Zubaida.
No, I'm not raising my hand. Sorry.
Okay. Okay.
Hmm?
Okay. Dr. Audu.
Okay, thank you very much, the treasurer, for the clear presentation. I hereby move for the adoption of the report for the financial report by the treasurer. Thank you.
Okay. Dr. Olasheinde.
I second the motion to adopt the secretary's report.
Financial. Treasurer's report.
Treasurer's report. And also I have.
Thank you. So discussions. Dr. Olasheinde, can you drop your hands if you are done?
Just make my comments.
Okay, go ahead.
First is that we need to thank auditors actually did it.
We can't hear you again.
Hello?
Yes, we can hear you now.
Okay, I said I need clarifications concerning the non-current liabilities. We've been carrying this on for more than 2 years, and it's not good for financial reporting. If we owe people, we should please pay them so that we can clear our accounts. There's no point saying we have so much money in our bank account and yet we are owing some other people. So if we have the means and the funds, let's clear this so that in the next report, we don't carry on reporting this non-current liabilities. Thank you very much.
Okay. Dr. Amsa, maybe we take the questions together before you respond.
It's okay, sir. I'll try and respond to the ones that I can.
Professor Karim, sir, go ahead.
Yes, thank you very much, Chairman. And I thank the Treasurer for this well done job. My confusion, I just need the clarification. I don't know the difference between where you put you subtract and you now said surplus. I don't know what that surplus means. If for everybody, why is it different if you say bank balance? Why do you say surplus? That's just my area of confusion. There are some places you indicate you indicated like the domiciliary, dollar domiciliary. Yes, you said bank balance, but in some places you said total surplus. I don't know what that is. It balance? Is it different from if you say total balance or just balance? Because to me, it looks as if I don't know when it was generated. It looks. I don't know how to put it. Looks too simple, too general. If you say surplus. Thank you.
Okay, sir. Dr. Fajolu, go ahead.
Thank you, Mr. President. Well done, Dr. Amza, for that clear presentation. You mentioned during your presentation that the domiciliary account, what we have there is a grant. So I wanted clarification. Is there a grant towards a specific project so that that money is not for the association, but for a specific project so that we know that it's not our money and that it's supposed to be used for something specific? Can you please clear that? Thank you.
Okay. Dr. Olashende, your hand is still up.
Good afternoon.
Afternoon.
Okay, my name is Dr. Olatejo.
Go ahead.
Okay. I want to join others to thank Dr. Amsa for a beautiful presentation and for all the efforts she has put in place to see how how to generate funds for the association. So my own question also is in line with what one of the speakers have asked about the non-recurrent liabilities. I think it has been long now that it's high time we actually refund this money to the facilities that are involved. For instance, my facility is one of the three, and I think we need that money, even if it's just to get the irradiance meter, we will really appreciate. So we want the association or the executives to properly guide us. What do we do to get this money back? Thank you very much. Then the second thing is that I just look at our ARM and I smile because I remember where we have to start this ARM business. One of our elders advised that we should put our money there so that we could generate more. And so looking at it now, I'm smiling because having over 19 million there, I think it's high time we consider, we look into what we could do, what we could invest the money into so that we can actually make more money in future. Thank you very much.
Okay, we take comments from Professor Alice.
Thank you very much, and congratulations on the successful hosting of the conference and the meeting. I want to thank the treasurer for this beautiful work he has done and all the efforts at driving for money. I think it is not because of the election people have paid. People who want to pay will pay. Maybe they didn't have contact to pay. But where I want to make comment is that I appreciate the money we have, plenty of it, but I really want to feel the impact of our resources on the lives of the newborns in this country. If you are able to get, maybe we say this year, we can get maybe jaundice meter, CPAP machine, but something that will impact on neonatal life. And at the end of the year, we say we were able to do this. This is what it has done. I think that would be a far better investment of our resources. And then, or if we say we are using this money in improving the lives of the newborn, we cannot be having so much money and we're still recording so many neonatal deaths. And at the current rate we are going, we will not achieve the sustainable development goals of neonatal deaths of less than 15 per 1,000 lives. So I want to pray that we should rethink and see how some of this money we are investing in lives is far better than investing money in properties and other things. That is my humble submission.
Thank you, Ma. Dr. Amsa, can you respond to the questions?
My hand is up, sorry.
Okay, Ma, go ahead.
Maybe one, thank you very much for, and I'll join to really thank Amsa, the treasurer, for this wonderful representation. Number one is, please, I want to add my voice to this non-essential, about that radiometer, like Lifeline, $4,000. I really, where do we stand? Because I know in previous meetings, we had said to refund this money to the organizations, or do they still want us to get the irradiance meters to give them? Because even remember that, I know that time Lifeline paid that $4,000, I think, for 2 irradiance meters, JM105, for $2,000 each. But today we are hearing from JNCI that they have irradiance meter for 250,000 naira. So we really need to know, is it a Lifeline is not even asking about this money? Because we've rolled it over for like 3 years now. Then, thank you. Then secondly, my second comment is, I also smile with Dr. Olateju. She was the treasurer and we invested this money in ARM from about 9 million, and then it has gone on to 19 million. And also to say that Prof. Sante took the words off my mouth, because I had wanted to say, are we just leaving this money to be growing in an account? Can we use it, even if it is the bag and mask that we don't have in the primary healthcare centers? NISOM is talking about no bag and mask. What can we substantially do with this money rather than just leaving it to be growing in an account? When we made that investment in ARM, the turnover was like 20%, 22% per annum. So at least there was even a year that we got like 5 million, 6 million on it. But now ARM, the money market has dropped to less than 4%. It was even 2% or 1% at a time. So the money is just sitting there, literally. So I think we need to look at what do we do? Why do we invest it in something else so that we now use the proceeds from it to be running projects rather than using the capital to run projects? Or maybe we can form a small committee that can work with the current and the incoming ESCO on this finance to see how we can make impact. Thank you very much. Over.
Thank you, Ma. We allow the treasurer respond to some of these issues, then we take more comments, please. Thank you. The treasurer.
Okay, thank you, everyone. I appreciate the commendations, and I will try to the best of my ability to address the comments and questions that have been raised. But I believe a number of them will probably be deliberations that the House will need to take as a group. So starting with the first one about the non-current liabilities, it's clear that these are long-term liabilities that have rolled over, I think, over 3 executive yes, 3 executives. So I think for over like a period of about 9 years or so. And these were for the, I think, bilirubino meters or the irradiance meters. And I also agree that it's high time that we reimburse some of these outstanding funds and discuss thoroughly how we are going to go about reimbursing these institutions back the money. Professor Iredi made a comment about the surplus. Well, surplus, it's the same thing as the bank balance. That was the balance as at 31st of the bank balance in the Naira account as at 31st of May 2021. But it's an accounting language that if you didn't spend more than what you had, then that's a surplus. So, but probably maybe next time we'll put it either as the balance, which we are more familiar with, or bracket it for clarity. Dr. Fajalu has asked about the DOM account, the money. It was actually not for a particular grant. It was actually a support towards the Kaduna AGSM. And for us to be able to continue to do ENCC step-down training. But shortly after that, the COVID pandemic began and we were not able to do any meaningful trainings subsequently. So it's not for a particular grant that we will now have to dedicate it for that purpose. Dr. Olateju also had the same comments, I think, about the long-term liabilities. And I share in your joy with, along with Professor Eziaka, about the ARM investment. This has really proved to be quite fruitful over the years. And it's high time that we actually find a project that we need to, a meaningful project that we need to either invest in further or projects that we can execute over the next few years. I believe the other one, yes, the Professor Inter also talked about the impact on of our resources on the lives of Nigerian babies. No doubt that is the mandate of NISOM, and I think this is something that the House should also discuss and deliberate on to see how can these figures translate into quality and impact the lives of Nigerian newborns. I'm not sure if I left out any other concern. I don't think so, but if there are any more, I can address them now.
Okay, Dr. Ide, your hand has been up.
Good afternoon, everyone. I'm so happy to be able to join in this IGSM. I want to just quickly echo some of the points that were raised on the investment. I'm seeing that we'll have about 19 million and what was accrued is 128. So clearly, the ARM is not giving us so much return. Personally, I'm sure some of us that were into money market and all, I had to seek other alternatives. So I think it's good that we look at other platforms for investment. Because 128,000, I don't know if it's over a year, it's just too small. Having said that, I think that we're also at a stage in the growth of the society where we are now seeing that we have some money, and then we're beginning to say, how can we use this money to impact lives? I want to support that sentiment. There are societies that we know do similar things, like the AAP, they support little grants that impact on communities and all to affect lives of people. So I think that we can look at that and see what we can do to also support small grants. On that kind of way, it will be a lot easier to administer. Otherwise, the issue of how do you disperse or how do you support? So people have to come up with some novel ideas, and then the society can look at that. So probably we'll consider that kind of avenue. So I think it's good that we look for another investment platform. We need to be making more money so that we can take a little portion and be investing in lives. We can't stop investing to make more money because the society needs money. Thank you.
Thank you. Dr. Zubaida, your hand is up. Dr. Zubaida, are you there?
Oh,
That
hello?
hand has been up for a very long time.
Can you hear me?
Okay. Yes, we can hear you.
Okay.
Good afternoon, everybody. I'm Zubaida Farouk from Kano. I would like to join in and congratulate the ESCO and particularly the Treasurer and the Treasury for those judicious financial reports, and also congratulate the previous ESCO for the foresight in investing such monies such that now we can see we are financially buoyant. I also concur that we can use the resources we have to impact on the lives of Nigerian newborns. However, I also believe a society like ours should have some monies with it so that we don't have to be going every year begging for money. So rather than spend all this money, we should aim to invest a significant proportion of that money and then use what is left for the small projects, so that over time, as the money grows, our ability to execute projects also grows. So thank you all and congratulations.
Thank you. Any no more hands? Okay.
Sorry, Prof, just
go ahead.
Thank you. So this is just to highlight what we're trying to put on the chart. For now, anyway, my discussion wasn't that we should take the money from ARM. I had said that the money now, the money market is not yielding. It has really drastically dropped. So that money is just like sitting there. So if it is, we can have a committee that can look into this financial process for NISONM. Where else can we invest so that we even have more proceeds? By the time we have more proceeds, we're not going to use the seed money. By the time we have more proceeds, we'll now use it to execute projects. Even the printing of the newborn discharge guide, it stopped because it was color printing. When you print it in photocopy, it doesn't show that picture we want mothers to get. So that little proceeds from that, and we can even get more source for more funds so that we can execute projects. Even the AAP we're talking about, they also get a lot of grants and donations. But the most important thing is to have those projects within the association, then they will seek for funds to execute them. Thank you.
Thank you. Professor Inte, go on. Hello, Professor Inte.
Her hand has probably been up since the first time she spoke.
Okay.
Yes.
Dr. Olasheinde.
Thank you very much, Chair. Just to sound a note of warning, well, maybe not warning, just a note of caution to us. We should not rush out of the ARM where we are right now. The financial market is quite unstable. No matter what instrument you move to, you can still not get the yield you are expecting. We need to set up a small committee, my suggestion, and seek further clarification from the financial experts. Some people rushed into dollar, moving money into dollar when it went to 500, only for it to crash 3 days later to 480. So we should be very careful. It's better for us not to get anything than to lose money. That's my contribution. Thank you very much.
Thank you.
Okay. May I?
Yes.
Okay, maybe can I just a few more?
Yes, go ahead.
Yes, it's obvious that the ARM investment is no longer yielding as it was at the initial onset. If you look at, unfortunately, I can't share. If I go out of this, it would distort things. But going through the ARM statement in the last 1 year, they gave us a quarterly update. And the first quarter, that was on the 1st of July 2020, the interest was 260,720 naira. By the following quarter, it had dropped a little marginally to 213,000. And then by the third quarter, it had halved to less than, in fact, half to 96,000. And by the 1st of April, it had further dropped by another 50% to 48,000. That was why we were only able to make about 500,000 naira over the preceding 12 months. So it's obvious that it's not making much yields, but as Dr. Leto said, it's very unstable now. And I actually have secured an appointment with the ARM managers, and I will at least link up the new exco with them. They are willing to discuss with us. They have other suggestions that we can invest maybe part or leave this initial tranche that we invested and then take just a part of it and invest in other aspects. They said they have other packages that they can move part of our funds to be able to yield better interest. So, but I also don't think we should rush in moving everything totally out. Looking at where we started from and where we have gone in the last 6 years, I think it's still too early for us to just bail out now. Thank you.
Thank you, Dr. Amsa. There are no hands up.
I think I have my hand up.
Okay, Prof, go ahead.
On my hand.
Yeah, I was just going to commend the treasurer for such an excellent report and for the great commitment she has shown to mobilize all these resources. But on the other hand, I want to agree with the idea of setting up a small committee to look into investment opportunities, money markets, how we can identify the grants to support and the rest of it. It's not something that we can just talk off the cuff about, but the discussion is a healthy one. Thank you.
Thank you very much, ma'am.
Professor Ebun.
Thank you so much. I think I'll just add my voice to the previous speakers. Thank you, Treasurer, for a job well done. I was just wondering, as we discussed this 19 million, as if it was 900 million. You know? I think that like we have an aversion to money because it's like, this money is too much, you can't keep it like that. I think it's too soon to say that. There are quite a lot of things that we can do, that we have done in the past, we can do other places. When the money is much, we can do interventions in different zones, something that we can be the one that will be the whole sponsor from the beginning to the end. As somebody said, we can give research grants, but we still have a long way to go. 19 million is a lot of money, but it's too small to start getting ourselves worried. And I think what somebody had cautioned us, I think it was Dr. Leto, that we should not even rush to come out of the market yet. Yes, it's not yielding anything, but we're also not losing by being there. So maybe it's a safe way to just keep the money there and then look at other opportunities that are available, and we can then key into it. Thank you very much.
Thank you, Prof. So I think we have discussed much. Can we move on? What's the next on the agenda?
is the hosting right to discuss the
next AGSM.
Next AGSM, yes.
Okay.
The Asaba 2022 and the Lagos 2023. Thank you.
Thank you, Dr. Yilo. So going by our previous agreements, the Bayelsa, after Bayelsa 2020, and next is Asaba 2021, then Lagos 2022. We were unable to host an AGSM last year. So Bayelsa is now 2021. Asaba will then be 2022 and Lagos 2023. So do we go on, just move on like this? Let's have suggestions.
Yes, sir. I think we should just move on.
Okay. So we just call. Are there other comments?
Hello. Hello, sir. I wanted to find out, Mr. President, that obviously some people indicated from Lagos that they wanted to host it in Lagos.
I think it would be nice to hear from Lagos. Since Asaba has accepted the hosting right of 2022, let's hear from Lagos.
And then those who indicated originally, if they are still on, we should know that instead of just assuming that.
Through the chair, thank you. Dr. Fajolu had her hand on because I know I wasn't at the Kaduna.
Fajolu
you
was
have your
around.
hand on, or do we? Please, Dr. Fajolu, speak. Did you accept for Lagos?
That was a mistake. My hand wasn't actually supposed to be up because I wasn't. I wasn't at the Kaduna meeting either. I was at the Kebbi meeting. I wasn't at the Kaduna meeting, so I don't know when this. Even though I remember in Kebbi that there was some proposition that Lagos should host 20. I mean, the one
21
Asaba was going to host, and it was declined. That's the much I know. But I wasn't at Kaduna, so I don't know when this.
I think these decisions were actually discussed in Kebbi. And
Mr. President, you're right. This was Kebbi decision.
There are decisions carried over.
It was Kebbi.
Okay.
Go ahead.
Yeah, through the chair.
Go
I
ahead.
really don't know why Iriti and Chinyere are hesitant to host us. They are capable, and I know they will have enough support. So I support that Lagos should host. Thank you.
Thank you, sir. I also think so. Because when we discuss in Kebbi, even Kaduna refused their own. We had to discuss over and over, but they hosted it very well.
Hello,
So
Mr.
truly,
President. Sir.
Yes, ma'am.
In our minutes, we didn't say who bidded. Usually somebody, because there's somebody in was Dr. Professor Gisu or somebody else from anywhere else in Lagos there. We need to know who bidded for Lagos originally.
Well, I am not sure, but I know Professor Kolo bidded for Asaba. I am not sure of the person that bidded for Lagos now. Yeah, because it was the other. I didn't see that in my notes.
Because
so even at that, Lagos can do it. Lagos is too big. They have LASU, they have Uniluf. They are quite a large, half of the country.
Anyway, but is there anybody that is like really ready to host?
Yeah.
Just before Lagos, Prof. Sebun, we've not come to Ife.
We are ready to host if you want to come to Ife. By then we have an airport in my university, so you come.
Airport?
Yes. No?
Dr. Fajolu, your hand was up.
You didn't read it in the news?
From Asaba to Ife.
Lagos was to.
No, Lagos.
Yeah, because hello, House. We're also looking at airports
votes
where people can fly into.
Yeah.
That's why we chose Asaba and Lagos.
Okay, so where they cannot fly, they
by
shouldn't come at
consensus,
all.
For now,
Dr.
for now.
Zenwa, then Lagos will have to agree. Dr. Zenwa, Lagos team, speak.
I think we should host, Prof.
Okay.
Lagos should-
I hereby agree because I can't take that unilateral decision. Now the Lagos team are agreeing to host. Thank
there
you.
are other people in Lagos, so we will be able to.
Okay, please, the Lagos people. Dr. Disu. Olutogun
Letu has agreed now.
Dr. Letu, yes, of course. Dr. Letu was number one. He may even be the conference chair.
Echo for sure.
No, it's the money back, so don't worry, you have support.
Dr. Letu money back.
Dr.
Yes,
Ezenwa,
thank you.
your hand is up.
Olutogun, I saw you earlier.
Lagos should host. Thank you.
Thank you. Thank you.
Thank you. After Asaba, thank you very much. So we formally agreed. Thank you, everyone.
Thank you.
Thank you, Lagos team. So after Lagos,
Okay, sir.
do you agree, Ife?
Okay, yes.
After Lagos.
Yeah, welcome. Anytime.
Okay. So Ife will host us after Lagos. Thank you.
Have they agreed?
All right.
Yes, they did.
Okay.
So Ife has agreed to host?
Yes.
Great. All right. The next point now is AOB. Any other business, and then we'll read the communique and dissolve the ESCO.
So AOD, Professor Inte, your hand is up.
Sorry, thank you very much. The AOB I want to raise is to thank the executive for the beautiful work and to suggest that we must actively look for opportunities to make the mental health issues visible in programs, in everything. Last month, I attended a meeting where they were drafting the national policy, national action plan for children. It took me a lot, reflected something.
We can't hear you again.
To recognize the special vulnerability of newborns so that some resources can be put aside to address some of these challenges you are talking about. So it's something I really want us to take on and move to our centers, our hospitals, wherever we are. Because many times newborns are bonded intervention and are implementing. Many of them address the needs of children after the first 1 month of life when they are most vulnerable. So I'm hoping that every one of us will start actively advocating for more visibility for newborns in every local, national, or whatever program we see around. And then, like when I went to that program being hosted by they should also include pediatricians, obstetricians. It's not too much to do, so that when the resources are being put aside for implementing issues for vulnerable children, newborns will be given proper attention. Thank you very much. I am done. Thank you, Chairman.
Thank you, Ma. Any other AOB? Okay, so we move on. Dr. Ilo, what's next?
Yes, Mr. President. What's on here now is the reading of the communique.
Okay.
But the chairman of the communique drafting committee, Dr. Chukwudi, has tried severally to send in the initial draft that the committee has to share.
Yes.
But it's been corrupted. So we can't, I don't have a clean copy to share now. So I don't know what the House will decide, what we can do about it.
Okay. So do we allow the two secretaries, LOC and NISOM secretary, to look at it and share with us? Since we can't, they have tried and we can't get it. Professor Ebum, your hand is up.
Sorry, I understand what I understood from what Dr. Kene said is that trying to send it to Kene, but he can share from his own computer.
Okay.
Okay. And then if not, let him read it out to us so that at least we have an idea. You know, people can make contributions.
Okay.
Not just blank at it.
Okay. Professor Ibe, sir.
Just to reiterate what Professor Ibu just said, it can be read out, and the key points should be discussed.
Okay.
Okay. Let me ask him to see what he can do.
Good evening. Sorry, I didn't forget our agreement, but the NISOM meeting is still on, and I'm not sure whether we can meet again today.
Hello, I can't get through to him. So do we choose the option of sharing it with the participants, some of the participants, for us to make inputs before we finalize it?
Dr. Kenneth, excuse, through the chair, I know there were other members in that committee. Dr. Taslim, the assistant secretary, is part of the communique. No other person has
Prof.
a copy. The assistant secretary, Dr. Taslim, is part of the communique drafting committee.
Yes, Taslim is in a meeting. He has an advanced visiting board. They're having accreditation.
Okay, he's
I've been
not
trying to
at this
reach him
meeting.
too.
Okay, all right. Thank you very much. Prof. Sibe has his hand up.
Okay, sir, go ahead. Professor Ibe, sir. Hello, sir. Professor Ibe.
Hello?
Hello, sir. Go ahead.
Yes, I said in the circumstances which we have now, the committee drafting committee should be able to liaise with with the secretary and the incoming executive, and look at the communique. They should be feel free to share to members through the WhatsApp, and if there are any comments, then they can do that. So we can move on.
Okay, sir. Thank you, Prof. Thank you, sir. So the next
dissolution of the ESCO.
Appointment of returning officers first, I think.
Yes.
Okay.
So you give your closing remark.
Okay. Evening once again, all. On behalf of the outgoing NISOM Executive Committee, I want to appreciate first our teachers and trustees for all the support this set of ESCO has had from you since inception till this moment. We quite appreciate all the support you have given us, and to also our members, we appreciate the support given to us, without which we wouldn't have achieved the little we were able to achieve. We thank you very much. So before we dissolve the ESCO, we want to appoint returning officers. Professor Ngozi Ibeziako will be the returning officer, to be supported by Professor Karim Airede. Thank you. Are they around?
Yes, I'm around.
Okay. So after this, the ESCO inaugurated in 2018 is hereby dissolved for us to proceed with elections. The election itself will be will also be virtual. And all financial members are eligible to vote. We will be given a time, okay? That's the voting rules being projected. Ensure that your email address is
Excuse me,
yes,
Mr. President. Before the solution, has a vote of thanks been moved for this ESCO? I think the outgoing ESCO deserves a vote of thanks.
Okay. Okay,
can somebody move this vote of thanks, please?
NISOM, a hand is up. Go ahead. NISOM.
Lillian.
Good evening, sir. Good evening, everyone.
Good evening.
I actually wanted to, I thought Prof was going to move the vote of thanks and then I'll second, because I think the ESCO have done excellently well.
Thank you, Ma.
She's part of the ESCO.
Prof will give, oh, okay.
She's part of the ESCO.
Yes, we're part of the ESCO.
Okay, so I believe that if this is a privilege, you know, for me to be able to express the gratitude of the entire Congress, you know, for the good job that this current ESCO has done. We appreciate you so much because it's been a very challenging tenure, you know, with the COVID and all of that. And yet you have, you know, stood your ground and you have stepped up and shown leadership. We thank you for all that you have accomplished. And we pray that the incoming ESCO will, carry the torch forward and take the society to greater heights that you will be proud of. So thank you so much for all your efforts all the time, the sacrifices, the sweat and everything. We pray that God bless you in amazing ways and your families too. Thank you so much. God bless you.
Thank you,
Seconded. Thank you very much, ESCO. Well done.
Thank you. So with this, we can go ahead and dissolve the ESCO. The electoral committee has been put in place. So the ESCO stand dissolved for the electoral committee to proceed with their election. Thank you. Professor Karim, sir.
Yes, my colleague, I don't know if she's...
Yes, she's there.
Okay.
Can you hear me?
Yes, I can hear you.
Okay.
We need to know I thought you said they're going to project the, maybe the offices to be contested for.
The rules, yes.
The rules. As well as, of course, the major determinant there is the financial status of any voting member. I don't know if we're going to project that.
So the treasurer needs to tell us the number of persons that are qualified to vote.
59, ma'am.
Hello, was I heard?
Yes, ma'am.
Yes, we need to know the number of eligible voters.
No.
The list is being projected now. There are 59 members that are in good financial standing.
Okay, 59.
59,
59.
59.
Okay, good. It's been projected. Okay.
So, Professor Irede,
yes, ma'am.
We need to know the number of the posts that are eligible to be voted for.
Yes, I also want that to be projected so that we all see the posts to be contested for. Because apart from the main post, I don't know, do we also contest for ex officio membership? Okay. So there are 5 positions.
Okay. Now, I think the ICT people have a platform for the voting, but before then, we need to call for contestants. If you start from top to bottom.
Yes.
All right. So please, Irede, can you please go on and call for nominations?
Yes. Having been duly elected as the electoral officers of our great NISONM, we have seen the post being contested for. I think we now call on the participants to please nominate from top to bottom, the first being the vice president's position. Any nominations?
Yes, sir.
Yes, identify
Yes,
yourself
sir.
and then go on to do the nomination.
Okay, I'm Zubaida Farouk. I nominate Dr. Maria Mukhtar for the post of Vice President.
Okay.
Seconded by...
Any seconder? Without any support, I don't think that will be accepted. There should be a seconder.
Hello? Hello?
We can hear you.
Yes, I second. My name is Dr. Audu Lamidi. I second the nomination of Dr. Maria Mukhtar as the vice president.
Okay. Yeah, thank you.
Electoral officer, I have a nomination.
All right, ma'am.
I nominate Professor Boadeju Ibe.
Sorry, I didn't get it.
I nominate Professor Ebu Adeju Ibe.
Okay, you had not added. Okay.
Did you hear me?
Very well. I said you had not added. You had not added the name Ebu, but it's well heard. We are taking it, ma'am. Any seconder?
Motion.
Any seconder?
Yes.
All right.
I second the nomination.
Who is this seconder?
What's your name?
Ridon Ide is my name. Ide Ridon.
Ide Ridon. Okay, thank you. So we've got a seconder for the nominee of Professor Edmund Adeju Ibe. Any other nomination?
Maximum of 3
2
nominations for each post. Sorry, sir, before we continue, somebody just made an observation that there is no post of secretary on the post being contested for.
No, okay,
we have vice president, then assistant secretary. There should be a secretary there. In fact, the assistant secretary is not voted for, is nominated by the secretary when elected.
Yeah, that's true.
Yes, it should be the secretary.
We just change
It's true, it's the secretary, please. You should
okay, so it's not assistant secretary, but secretary.
But yeah, that's what it should be.
Okay. So what do we agree on? The 2 nominees are okay, or we should have 3?
We can call for a 3rd nomination, and if there is none, we close nominations.
Any other nomination for the post of vice president?
I thought we were told 2 nominations.
It's 2 nominations, so.
Okay, sorry. Okay,
no.
so nominations closed.
No, I don't know. How do we know it's 2? The electoral committee can decide otherwise.
Maybe
right.
maybe it's constitutional.
All right. So we have had these 2 nominations. Now, what about for the position of the secretary?
No, let's finish with is the president-elect or vice president now? I think the ICT team should give us the platform for voting. Am I right?
Yes.
That's how we do it.
Okay, I thought.
I'm not sure that we know how to vote. The procedure for voting is not clear.
I think we can vote for only one person in a position.
Yes.
Yes. Please, can the ICT team guide us?
Hello.
Please, sorry, my colleague in this electoral committee, I thought if we had listed out all these positions and then we nominate candidates for these positions, then we cannot carry out this voting for all at once. And then
Yes,
they
it's
have it.
electronic.
Each position carries the vote.
Yes.
Okay, my dear colleague.
Okay.
Like we do when we have our physical meeting.
Oh.
Sorry, I didn't hear that. When you have physical meetings.
We do one at a time, so we should
Yes.
just move one at a time.
Well, one position at a time.
Yes, one post after the other.
All right, we're just trying to find out which will be the easiest way out.
It is easier. Let's just do it across
Hello?
board.
I
Hello,
agree
please,
with
can
Prof. I agree with Prof because one position does not determine the other one. So let us vote them separately. Thank you.
Yes.
Yes, sir.
Separately.
Okay. All right, so we're now saying we should carry out the voting process for the position of vice president first, then we'll go gradually downwards, post by post.
Yeah.
Yes.
But their name should be typed out, sir.
Hello, sir. This is the ICT.
Secretary. Even if it's only one person for chairman, president, we should have option to say yes or no. So it should also be put on the list.
Yes.
You can only type out the names when people are nominated.
Hello, sir.
Yes, please.
Please, I want to lay out the guidelines for voting. So once we are done with the nominations, it will be clear enough.
Okay.
And the IT put us through, please.
Yeah, this is the ICT. This is the ICT speaking.
Okay.
Please do.
Okay. So, okay, the very first thing is this.
Yeah.
We have the voters list, which we have already shared.
Yeah.
And the email address on that list of the financially up-to-date members is the email that has been inputted to the system as a certified email, because the system checks against double vote and it does not allow those that are not financially up-to-date to vote. So when it's time to cast your vote, you visit any of these websites displayed here. Number 2 may be preferred, since it is the characters are okay. Let me share my screen. Just a minute, I'll share my screen.
It's not very clear.
Okay, just a minute. Okay, please, is it clearer?
Yes, you can see
it's better now.
Okay. So once you visit this site now, I'll try to do that so we see what I'm doing. Once you visit the site,
It's not clear.
Yes, I'm
again.
going to share my
It's
screen.
back.
I'll share my screen. Can you stand by? I'll share my screen now.
Okay.
Please, while you are doing that, the list was just run through and I couldn't see my email to verify.
Okay, we are going to display it again.
Okay.
Also, if you are in the NISONM member WhatsApp group, I've just shared the list.
All right, I'm just checking on it now to see if it's okay. Yeah.
There's some changes. We're gonna go to stretch.
Okay.
Okay, please kindly stand by. Just 30 seconds. It's loading up.
Fine. Thank you.
Please, while that is being done, my email address is not correct. That's why I was saying to check it, because my vote will not have registered now. Please, I'm going to write my proper email address.
Please write your proper email address.
Okay.
Okay. So once we go to that website, it will direct us directly to the voting platform. And as you can see here, this is the position of the vice president only displayed. So assuming the number one nomination, if his name is called Python, number two, the name is PHP, number three, JavaScript, you simply select your preferred choice.
Okay.
Then put in your name, first name, last name, and email.
Okay.
If I click on vote now, the system tells me that my email is not on the accredited list, so I can't vote. But if my email is on the accredited list, the system would accept my vote. So it's as simple as that. We'll put in the website address there. It only displays what you are meant to see, which is just the position you are voting and the candidates of choice. You select a particular candidate, put in your first name, last name, and email address. So that will be all. When we are done with this, we take the next position, and the next position. Then we are done with the whole session.
I don't need it.
This email address is not clear. Please.
So I'm going to share the voters list now, so we can verify.
The website is not. It's still blurred. The website. The site.
I'm dropping it on the chat platform.
It was clear as presented.
It's not clear.
I've dropped it on the chat platform.
Okay. That's the second one. Leave it there. Let's copy this one first.
No, he says the second one is the preferred website.
Oh, okay.
Yes, so please use the second website.
bit.ly NISONM.
Yes, bit.ly/NISONM.
Okay. But it's not allowing me to copy.
Look, you can't be gone. Take the time.
Made the payment to you, Dr. Elitu.
So, Dr. Irede, we will allow participants to vote now that it's clear what the
I need to vote. Otherwise, you guys are not coming to Lagos.
Sorry, ma. I can see that it's still on Python and the rest. The names are not there yet. It's still Python and what
I see.
The website is not even copying.
No, it's even open, but it's still saying Python and
otherwise
PHP.
I would have paid.
The names of the candidates are not there yet.
Hello, please, we have not displayed the names yet. Since we have not concluded with the names, we have not displayed the names.
Okay, then.
And once we are done with the voters list, we will display the names.
Yeah. Please correct my email
We have
address.
the voters list and the
Since voting has not started yet. Thank you.
Please, can voters go through the
always include
voters list again and verify your
voters list now? So let him add it, please.
Okay, this is a voters list being shared.
Verify your email address.
Can we scroll down?
Okay.
Gradually, but what can we see now? 1 to 6, are they correct? If they are present?
Okay, we have sent the list to the WhatsApp platform and to the Zoom chat platform, so you could open it directly on your device.
Well, I can't see it. Okay.
It's on the chat platform.
Okay.
And so if we open the list,
if there's an error with your email, you please kindly drop a message on the chat.
I have done so.
Did anybody see my name? What number am I?
Number 9.
Number 9.
Number 9.
Yes, sir. Yes, ma'am.
It looks correct.
Please, I can't see
Number
the rest.
10,
I'm
number
only seeing
10.
1 to 13.
I can't see my name.
I've seen my name now, but I can't see my email address.
I can't see my name, which is my own number. Listen to.
I can't see my name, Zubaida Farouk. It's not there.
My name is number 10, but where is my email address?
Your name is number 9.
Your name is number 9.
Yes. What is my email? The name that is number 9 on the list I have is Professor Ramabo.
Hello, my name is not on the list.
Then it means you are not.
Your one is there. Number
Your
56.
name is number.
Your name is there. Your name is there, Zubaida.
Dr. Zubaida.
Yes, ma'am.
You are 56.
Okay, ma'am. Thank you.
Zubaida Farouk 56. Okay.
Yes, ma'am.
The list being displayed on the screen cannot move.
What of my own name?
Please, can you take the list up again? Yes. No, yes, okay.
Please, can someone assist us to type the names of the nominated members for the vice president, please?
Okay.
We didn't get it clearly.
Not yet. Let us verify these email addresses.
Go. I've not seen mine. No.
My own is anenolista@gmail.com. Professor Kolo is your correct email address.
Yes, it's correct.
I've not seen mine. No.
Who are you?
This Professor Ben Onanko, I've not seen mine.
Are you financially up to date?
Are you sure you're not owing?
Ben Onanko, no, I'm not. No.
If you are owing, then you won't see your name.
No, my name will be there. I saw it on the WhatsApp.
Please, I'm not on that WhatsApp group. Can I be included?
Not now, man.
Hello.
39.
Okay. 39. Thank you. Yes, 39. Thank you. And my email is correct.
Okay.
Yes.
My email is correct.
Please, I want people to check email addresses, and because there are some case-sensitive email addresses.
So now that our email addresses are correct, what do we do?
No, I haven't seen my name. They have to show me.
Are you financially up to date?
Yes.
Your name is not there.
My name is not there. Okay, now that is fine.
Don't worry, you're there.
Oh yeah,
So,
correct my own. No.
Alice, is that a threat?
Hello, ma'am.
This number 52 would advise that you kindly copy out the email you are seeing displayed. You can use it that way it's displayed.
This IDEAH, it will not go now. I should use it like that.
Yeah.
Yes, the one we displayed on the screen will go through. So please use that one.
No, now.
Okay. All right. IDEAH.
So we have our name on the screen. So what do you advise us to do?
Okay.
And the next stage is to drop the nomination so we can input it to the system.
Okay.
The nominations for the vice president, please.
ICT.
Sorry, from Fufore.
ICT, you are the admin.
You lost a child before.
I've written the names for you.
9 years old.
Okay.
I sent you a direct message. I just used the short form of their names.
Okay.
Why not to full name?
So say.
So are you going to post the votes to our email?
Please give us 2 minutes. Please, can you give us 2 minutes while we input the names for vice president? Just a minute.
Yeah, your accreditation. In fact, in NISONM, so 2 weeks now, I don't know. Nigeria quite difficulty. Maybe okay, because I'm in Lagos this weekend. I'm eating up till Thursday. I'm leaving Lagos on Thursday. My intention is to come to Yola straight, spend a week, then the upper week in accreditation.
Dr. Mustafa.
Yes.
Can
we can hear your call, your private call.
Sorry.
Professor Irede, can we proceed?
Yes, we're waiting for the ICT. They want to impute the names.
Okay, thank you very much. Please, we can all visit the site now to vote for the post of the vice president.
So we go to our email.
No, you go to this website that is displayed here, either 1 or 2. www.
ICT, please be consistent. You said 2 is preferred.
Yes, you can. You visit www.bit.ly/NISOM. Then you can vote.
So I should go to the website.
Yes.
www. Please call it out.
www.bit.ly/NISOM.
Hello, ICT. I
The
can see
names are not showing. It's still Java, PHP.
Python, JavaScript. Which one do we click? There is Python, PHP, JavaScript, and Java.
Please, you have to refresh your page. That is the former page. Like we say, just refresh.
Okay.
Refresh. That's the former page you have been. Just refresh your page, please.
Okay.
So after selecting, we'll press vote, eh?
Yes.
Okay. Yeah.
I can't get the page.
It's displayed on my screen here.
It's a very simple, very simple procedure. The procedure is very simple.
It's not I can see the page. Can I go on and vote?
Yes, you can.
No,
Thank you.
We have already voted. Now we started voting already.
So this is the page.
Please display the address.
www.bit.ly.nice/NISOM.
Yes.
I can't get the page.
Opening.
Ready?
Please, can you do it again?
Okay. Look at my screen, please. www.bit.ly/NISOM.
Yeah.
NISOM, NISONM. Then you press your enter key.
It's not giving me that, it's giving me something else.
This one, can you see, ma?
Maybe I've missed something because once you do it, it comes out straight.
It's showing me Adela Adedoji. Please, don't matter. Oh God, what is all this nonsense now?
Forward slash.
Slash NISOM. Yes, slash NISOM.
Election.
Big double slash or only one?
No, only one. Only one.
So why am I not getting it?
bit.ly/NISOM.
Is there any space?
No, ma. No.
There's a dot. bit.ly.
Yes, /NISOM.
NISOM. NM.
NM, yes.
IT.ly / NISOM.
I can't get it. I don't know what they're saying.
Please, you have displayed it again.
It's not showing. It's not showing. It just
Where
goes
did
up.
you display it? In the website?
On your screen, you can look at my screen, please. You'll see it again.
Your screen.
www. No, you can't copy.
Oh, I wish we could copy now.
Please, can someone paste it on the WhatsApp group, please?
I'll do that. Let me do that.
Please, are other people having challenges?
Yes, I'm having challenge. I can't see.
I have voted.
Access it. I want to vote.
When you say slash, when you say forward slash, just say slash alone. LY slash. Don't say forward. If you say forward slash, you cause confusion. Just say LY slash NISOM.
Please, I can't get it. It takes me to a Yahoo page. I don't know. It takes me to a Yahoo page.
I have put it on the WhatsApp. The address is on the WhatsApp.
It's now in the WhatsApp page. Please, you can copy from there.
ICT, which stage are we now?
It's in the NISOM page. If you're having issue, go to the WhatsApp page and copy it and paste.
I've opened on my phone.
Preferably use your phone. The phone is faster.
After ICT, after casting your vote, what do you do next?
After we have voted, what do we do?
After casting, we wait for others so we can see the results. We wait for others to vote.
Dr. Irene, Professor Irene, can you hear me?
Yes.
Okay. That is, for how long will we let this continue?
So are we voting Maria? We
went faster. I
Wow,
have voted.
Has everybody finished voting now?
So I made here, and the man able to okay. No, we'll let them. So let's give Maria this one. So I'm voting. Yes. Okay.
How do we know now if everybody has voted?
Okay, we are going to display the list of those that have voted so far.
Okay, display the list so that I will know my vote has gone.
You can display so that we know out of the 59.
Accredited email address.
Oh, wow.
We should have just done everything together at once, and then we just get the result at the same time.
That's what I thought of.
Yes,
I agree with that. We would have done it once. Put all the list on the project. Then everybody will go and rest.
Yes, vote for each category of person you want to vote for, and then you move on.
No, but the issue is that after voting for someone on the post, can the person not, is it against the rule for the person to say to be nominated for another position?
No.
So we can take it one at a time quickly. Now we have sorted out all the email and website address. It will be smoother now. Then we can just go ahead.
That's
okay, for what we have here, 39 people have voted.
The other 20 don't want to vote.
Please, for what we can see on the screen, we have 39 voters so far.
Let's know who.
Hello.
Let's know those who have not been able to vote, because it's possible that many people have left.
Hello. Please, you don't have to display this.
Okay. So we just have 39 voters. Please, others should vote so we can go to the next position.
Members of the
But it's not
electoral committee.
opening. Like mine is not opening, in spite of all I've done. So how do we go about it now?
Wow.
Please, has everybody who wants to vote, have you voted?
It's been challenging.
I'm
trying to.
I think we can apologize to those who cannot vote now.
Please, we'll just give maybe we should just give just 5 more minutes so that after that we close this voting for the vice president and move on.
Okay, we have all heard that. So 5 minutes for us to try and correct the errors and vote so that we don't stay here till tomorrow. Now, we didn't highlight this at the start of this voting process. Are members of the electoral committee expected to vote?
You are.
No, they can't vote.
No, they can't vote.
I don't think they can vote, sir.
No, you cannot vote.
Hello. Good evening, all. There is no law against members of the electoral committee voting. If they are paid up members, they can vote. It is their right. You cannot deny them that right.
Thank you. Thank you.
Why haven't you voted?
Partisan INEC.
We have about 2 minutes more.
Hello. Please, I didn't vote. Too. I started voting before it all started, and it's reading that I voted.
Hello, good evening all.
Yeah,
I
good evening.
think there shouldn't be any time limit as to when people can vote. We can continue voting until the last elected post has been completed or voted for, and then we can read out the results thereafter. So the fact that I have not voted now doesn't mean I cannot vote in 10 minutes time or 15 minutes time.
Okay, let's go to the next one.
Yeah,
then.
but we have to keep a time limit. We're going state by state or position by position.
This is why we said they should do everything together. Let's put all the names
It
together.
will be better to put all the names up and people can vote at once rather than going one by one. We are wasting
One by
time
one. This
on
one by
this.
one is not causing trouble for us.
Is that the consensus?
And is it possible, IT team?
I don't know if it will be possible in view of
It's
the
possible from our end to display all on one page. It's actually based on the preference of the electoral committee.
That's what should have done.
That's what we suggested at the beginning.
What is that? What is that?
Language.
No, translate.
So what are we doing? What's the next stage now? My
That's not part of the voting.
Well,
No,
I don't really know what's this difficulty with us being able to log on and voting. Would have done with this first stage long ago now. So what's the problem?
What are we waiting for? What's
Please
going
let
on?
us put
Please, we
all
need the names for the next
nominations
nominations.
and
We need
give us
their
time
names.
to vote.
Have
During
we
national
finished
elections, we are
voting?
giving all the papers for nominations,
Okay, I want to
and we vote at
for
once.
the post
They won't say
for
go
the
and
post
vote
of the
presidential, come
secretary.
back and
I want to
vote
nominate Dr. Izano
governor.
Sorry, who is
Any
nominating now?
secondment?
So we are going into these other positions now without knowing the results of the penultimate voting. Is that what we're doing now?
Yeah, it will all come at the same time.
Pardon?
The results
I
will be
thought we were
announced
meant to
Yeah,
know the result of one to move to the other.
No,
no. Beginning. So who is nominated now for the position of the secretary?
For the post of the secretary, I nominate Dr. Izano Sike. I'm Dr. Ilo, former NISOM secretary.
Okay, you are nominating Ize
Anosike.
Anosike. Okay, from the former secretary. Any seconder?
I second.
Who is seconding?
Chap Jumbo.
Okay, Jumbo is seconding. All right, that's well taken. Any second nomination? Position of secretary?
Unopposed.
Unopposed?
Okay, progress.
No other nomination.
Any other nomination? Over the next 5 seconds. Okay, so in the absence of any other nomination for the position of the secretary, Dr. Ize Anosike stands unopposed, but will still vote to say yes or no.
Yes.
Do we have to vote?
No need now.
I'm not sure we have to vote, sir.
If unopposed, we don't need to vote.
There may be some hidden agenda.
Let us vote to let it be on record that everybody.
There was no nomination now. It's only he that
No,
was
there's no other contestant.
Please,
There's no
We must have a person in that position.
Hello, please. Let us vote.
Please, can we go ahead? He's unopposed, please. We're not voting for another
unopposed.
person,
Let's
please.
move on.
We're having challenges with the electronic system. Since he's unopposed, let's move ahead.
Let us move on. Unopposed.
Next,
All right, what's the next position?
Okay.
Treasurer, isn't it?
Treasurer. For the position of treasurer, any nominations, please?
I nominate Dr. Iretifa Jolu.
Sorry, Dr. Ireti.
Fajolu.
Please, who is nominating your name?
You should have known from the
Zaka.
voice.
Okay.
That's why I did ask. I knew the voice.
I support the nomination. I support.
Good evening, sir.
And who is supporting?
Angelo Kolo supports
Oh,
the
sorry,
nomination of Ireti Fajolu.
Okay. Fajolu. Okay, that's well taken. Any second nomination? Any second nomination? There is silence. So this is again unopposed.
Unopposed.
Unopposed. Okay. Now for the position of what's the next one?
It's ex officio 1. Ex officio 1.
Ex officio 1.
Good afternoon, Prof. I am
Yes,
Dr. Ridwan Jega. I nominate Professor Ben Onankpa for ex officio 1.
Okay, Ben Onankpa. Any seconder?
Good afternoon, Prof. I am Dr. Ali Mohamed. I second the nomination of Professor Ben Onankpa for ex officio 1.
Okay. That's well taken as a seconder. Any second nomination? Okay, there is silence, so that's unopposed. Ex officio 1. Ex officio 2.
I propose the nomination of Dr. Ridwan Ide.
Ridwan Ibe.
Not Ibe, Ide.
Ide.
Oh, Ide. I-D-E.
H, I-D-H, Obama.
I-D-E-H.
Prof.
Yeah.
Hello, sir. Sorry for
Prof.
Yes.
Professor Ma. You know my circumstances, so.
Yes.
I propose the nomination of Professor Kunle Olowu.
As ex officio 2.
We are still in ex officio 1.
Well, no, we are still in ex officio 1.
No, we've done ex officio.
We have done 1. 1 is unopposed.
Oh,
yes,
okay.
Yeah. We're now in ex officio 2. Ex
Hello,
officio
sir.
2 now. Who is
Clarification, sir. Hello, sir.
Nominated Ridwan Ide.
I think for clarification, sir.
Okay, go ahead now.
Okay, so I'm asking that I thought the immediate past president would be ex officio 1.
No, it's not. That's PAN. That's PAN.
That is statutory.
And that is that's for PAN. No, it's not for us. We haven't been doing that now.
For us, we've been doing that, but they are not voted.
Yes, so I was wondering that. So how many should we vote for now? Should it not be 1?
2. We're voting for 2 now.
We're voting for 2, not for. It's only in PAN that we are doing. We started doing that.
No, even in NISOM, sir.
No,
excuse me. According to the constitution we have,
yes,
we have 2 ex officio.
Okay.
Apart from the
president and secretary that are outgoing.
Okay. So there are 4 ex officios.
Yes, literally. I propose Professor Kunle Olowu, the LOC chair now.
I support Dr. Kunle Olowu's nomination.
What's your name?
I'm a second seconder.
Angelo Kolo.
Now,
Ridwan declined.
Okay, Ridwan has declined.
Thank you.
But we didn't hear him decline.
Yeah, you are hearing me. Thank you very much, ma. My circumstances not permit.
So, Professor, please, can you remind us of the nominations for ex officio 2?
Well, from my records here, ex officio 2 nominations so far, there's none. Because
there's
what
one.
I have is Ide, who has declined.
I thought I heard Kunle
Olowu.
Yes.
Okay, Kunle Olowo, that's replacing Ide read on Ide now. Kunle Olowo.
Yes.
Kunle Olowo, yes.
And that has been seconded.
By who? We didn't hear
By
the
me,
second.
by Angelo Kolo.
Okay.
Okay, any other nomination?
No.
All right, there's none. So it's Kunle Olowo as who is standing on a post now. The next position, I think that's what we have, 2 ex officios.
Yeah.
Then I don't know what this advisor means.
There's a post for advisor of NISONM.
Sorry, please educate us. Is it not voted for or nominated by SP and Board of Trustees?
Yeah, so whom are we recommending now?
Do we vote for advisor or
No?
I thought it's nominated by
Yes, I
SP?
thought so too. I thought it was nominated.
It's
nominated for appointment, but not voted for.
Well, please, can the secretary tell us what the Constitution says?
Yeah, cannot continue to get
the advisor is nominated and voted on this floor, and is usually a position that's nominated, ratified by this house. It's not voted for.
It's not voted for.
Yes, and but it needs ratification by the house. Nominated and ratified.
Okay, nominated and ratified.
Sorry, who does the nomination? Is it ESCO?
I nominate Professor Chinyere Zaka.
Seconded, Dr. Fajolu.
Yeah, but while nominating for this position, advisor, it means, and you're not going to vote. It means you only have one nominee.
Pardon?
Do you have only one nominee if you say that the post
we
cannot
don't
be?
vote for.
So therefore, you have only one nomination.
Yeah, so what? How do we do this? What about the ratification of Prof talked about?
I can't, there's so much noise. I don't know where the noise is coming from.
Professor Irede, it looks like voting has been completed. Professor Irede.
Yes, please.
It looks like voting has been completed. So we'll go back to ICT to give us the results.
Okay, ICT.
Hello?
Yes, that's ICT.
Okay, yeah, we are here.
Okay, so what is the result now?
Okay, you just a minute. Okay, so at this stage, we are disabling the voting from going on that. That's for the vice president. No one will be able to vote anymore. So the system will be shut down for that, so we can generate the results.
Okay.
Then where were you? Why didn't you vote? Where did you go to?
And then just keeping quiet. Huh?
ICT, please remember.
Yeah, please stand by. Just 2 minutes. We are compiling it now.
Just hold on. Remember that this is secret balloting. No display of who voted and who didn't vote.
But it's already displayed
the
now.
number.
But it's already displayed now.
We did
It
not
was
see,
not
we
clearly
did not
seen.
see
It
it.
was not clearly identifiable.
You say?
We did not see it.
It was not
I
clearly
was
seen.
seeing it initially.
Total
Yeah,
number
well,
of voters.
it was a
Total number of
mistake.
voters.
Because I saw it initially.
Total number of voters, 39.
Yeah, total number of voters, we are 39. So we are about displaying the result. Just a minute, we are displaying the result.
Okay. Hey, serious now. Just one day in the future, no whatever.
No vote pad in Ako. INEC, no vote pad in Ko.
No.
It's allowing them to grow. Okay, I have seen it. That's why I said everything.
Okay.
So Maria.
How you doing? I know President. Yes, sir.
Sorry, ICT.
That was dead.
But not so long ago.
That was dead. That one don't pass. Now next week we do. So how are you? Yeah.
No private chat. So
ICT, please, we need a total display for all the posts.
Okay.
And this total doesn't come to 39. It's 38.
It's 38.
Okay. On the Excel list, the first column was for the title. So we actually have just 38.
Can we have a total display?
Okay. Please, we need the names for the other nominations so we can add it to the table.
Okay, I read it, please.
Okay, the other nominations for the secretary, Dr. Eze Anoisike.
Eze Anosike.
Please, can we get the spelling?
Not a Nigerian.
I'm sending it to you as a private chat.
Okay.
Anoisike.
A-N-O.
S-I-K-E. Treasurer. You've got that one?
Eze Anosike, yes.
Yes. Now treasurer, Dr. Ireti, I-R-A-T-I, Fajolu. I hope I got that well. F-A-J-O-L-U.
Yes, we got it.
Eze Anosike is one surname. I hope you know.
Yeah, we got it right.
Then the other name should be there now. Please, the second name.
Anosike, what's his first name?
Obum. O-B-U-M.
Okay, ICT, the secretary is Dr. O-B-U-N, Obun. Is the Anosike is a compound name? Is it dash?
It's one name, it's not.
Oh, I don't understand though. Is it?
No, like you
is
said,
the-
Ireti Fajola. Obum and as well as Anosike. You know, like that. Okay.
Not Yola.
Okay, I don't understand. Is Anosike?
Surname.
Okay, it's together. It's A-E-Z-E-A.
One name.
It's
Okay,
one name.
Anosike is one name. There's no
O-B-U-M.
Obun Anosike. Then Ireti Fajolu. What's the first name of Ireti, please?
Ireti is one name.
Ireti is one name. Okay. You got that?
Yes, we got it. Yes, we got it.
Official one. Ben Onankpa. Ben, B-E-N, Onankpa, O-N-A-N-K-P-A. Ex officio 2, Kunle Olowo. Advisor, Chinyere Ezeaka.
GVC.
So, can we display the thing? ICT.
Yes, we are displaying it in a minute.
Through the chair. Sorry, can I ask a question? The post of assistant secretary.
The assistant secretary is appointed by the secretary.
By the secretary.
Okay,
and he should be
yes.
ready to give the name now.
Yeah, because I know there was a proposal, Dr. Simon Pius, that works in Borno.
Are we voting for him? It's
not
appointed
voting.
by the secretary.
Okay.
He's the secretary.
No, you don't vote for the assistant secretary.
No, we don't vote.
No, I thought we were compiling the names now so that it will be ratified.
Let the secretary tell us.
Yeah, he's in Borno.
Hello,
He's in
the
Borno.
name is Onankpa, not Onongpa. Ben Onankpa, O-N-A-N. Good, thank you. It's wrong again, no. It's okay. No M. O-N-A-N. Yeah, it's correct now. No, put N there. N before K. N before K.
Yes.
All wrong again.
As treasurer too.
O-N-A-N.
Can we have
That is all. That is all. Off your mic.
ICT. Treasurer is Dr. Ireti Fajolu.
Okay.
And then, sorry, Ezeaka is E-Z-E-A-K-A.
Fajolu L.
Fajolu L.
Fajolu L-U, the last letter L-U. Treasurer Fajolu L-U.
Then Ezeaka is E-Z-E.
E-Z-E. AKA.
Hello.
Hello.
Kunle Olowu is one name. So it's Onyanye Kunle Olowu. Kunle hyphenated.
Hyphenated, please. Thank you.
Then the first name.
What about the first name? Kunle Olowu, first name.
Onyanye, O-N-Y-A. Abi?
Yes.
Onyanye.
Professor, are you ready?
Yes, please.
Okay.
Prof. Hello. Prof.
Before we conclude. Hello.
Kunle Olowu Onyanye.
Hello.
Onyi.
Yes.
Ma.
Good evening, ma. Spell your name now.
Your name. Good evening.
O-N-Y-A-N-I.
O-N-Y-A-Y-E.
Okay. Well, no problem. Look at I don't mind, but I'm not keen on it.
Onyaye.
I'm not keen on it.
O-N-Y-A.
Hello.
Onyaye.
No, because by this thing, I actually wanted me to go for a second. Professor Olu. You understand why it was like, no. But this one, so that's no problem.
Madam Chair.
Okay, we are done, ma. Hello. Sorry, the assistant secretary
ICT, you now to input assistant secretary.
Assistant secretary, okay.
Because we have been voting for them.
No, we are not voting. The secretary will now tell us who. Can Dr. Zanos please give us the name of the assistant secretary?
Thank you, ma, for the privilege. Dr. Deji Adeyemi will serve as assistant secretary.
ICT, please note. Repeat now. Dr. who?
Deji Adeyemi.
No. He says David.
The current LOC secretary.
Oh, okay. So, Dr. Irene, Professor Irene.
Yes.
Ezanosike is one name. You have split it now. His name is not Eze. Yeah, all right.
Yes.
Right.
Please, I think you can now pronounce the result of the
Yes, I
election.
was going to ask that you as chairing the committee, maybe you are mandated to announce that.
Okay. Ladies and gentlemen, can we have some quiet, please? Ladies and gentlemen.
Maria, your full names.
ICT, mute everybody.
Mokhtar Yola.
No, Mokhtar K.
Mokhtar Yola.
R.
Can
I spell it? Can I spell it?
No.
Please.
M-U-K-H.
So can I go on?
No, please. Is that your name, Maria?
No, it's not correct. M-U-K-H.
Not correct.
M-U-K-A?
No, K-H. H.
Okay.
T-A-R. No, T-A-R. Oh, no.
K-H-T-A-R. Mokhtar.
T-H.
Yes, please.
K-H. K-H-T-A-R.
Let me put it on the chat box.
Exactly. Mokhtar.
Yes, you got it now.
Yola.
Okay.
And Yola. Hyphenate it and then put Yola.
Yola.
Yes.
Okay.
Excellent.
You mean?
So, distinguished members of NISONM, at the close of voting, it is my privilege and honor to announce the results. For the post of Vice President, we have Maria Mokhtar Yola. Can we give her an applause now? Secretary.
Clap, clap.
Secretary, Dr. Obum Ezanosike. Assistant Secretary, Dr. Deji Adeyemi. Honorable Treasurer, Dr. Ireti Fajolu. Ex officio 1, Ben Onangba.
Bow down.
ICT, this one should be ex officio 2, not 1 again. 2, okay? Kunle Onaye, Kunle Olowu. And the NISONM advisor, Chinyere Zaka. Please, can we welcome the new...
Sorry, ma.
Who is our president?
To the chairman, the president is still not included.
President and the immediate past secretary.
Just hold on.
They are not voted for.
From the election. Now,
okay, the new president, Dr. Kemi Tongo.
Kemi Tongo.
Dr. Kemi Tongo. The surname is Tongo, so space.
Tongo. Tongo.
Tongo. G-O, not D-O. G-O. Thank you very much. So, ladies and gentlemen, we present to you the new executive team of NISONM. And we now hand over to the new president for her to acknowledge her team. Thank you very much for the privilege given us to conduct this election.
Thank you.
I didn't hear any clapping now.
No wonder.
So, Kemi, over to you, please.
Thank you very much.
Who's our president's face?
On behalf of the new executive council, on behalf of the new EXCO, I would like to express our appreciation to the past executive council, to our elders, to every member of NISONM for this opportunity given to serve. We believe you trust in our abilities, and that's why you have given us this enormous task. And on our honor, and by the grace of the Almighty God, we will not disappoint you all. We are counting on everybody's support because NISONM belongs to us all. And we pray that by the grace of God, through your assistance, your cooperation at all times, we would be able to, as NISONM, we'll be able to take the association to a greater height. We'll be able to improve the lot of the Nigerian newborn through your help, through your cooperation. And we believe that our elders who have been with us all these years, they will certainly not leave us alone. They will go the whole length, the entire journey with us. And to all the other members of the EXCO, the new EXCO, I say welcome on board because we have been around for some time with them. We say welcome on board, and we promise that we would all cooperate and work together for the good of NISONM, for the good of the Nigerian newborn. Thank you all and God bless.
We should prepare for the dinner.
Congratulations.
Congratulations.
Let's prepare for the Bayelsa. When are we going? Yeah. Where is the dinner?
Online.
The dinner.
The dinner is
online.
Dinner is online.
Yes, it's a cyber buffet. It's a cyber buffet. Yeah.
Online.
Congratulations to the new and the exiting EXCO. President.